Let me introduce our conference chairperson. She is Swapna Chaudhary, Professor Swapna Chaudhary from Chittaranjan National Cancer Institute, India. And I request Professor Swapna Chaudhary to start her introduction speech.
Okay. A very good morning to all the speakers, delegates, and student participants, and welcome to the global webinar on immunology. I'm Swapna Chaudhary from Chittaranjan National Cancer Institute. I work there as an emeritus medical scientist. And formerly, I was working at Calcutta School of Tropical Medicine, Kolkata. And I was attached to the Department of Laboratory Medicine as professor and head. For the last 40 years, I've been working on immunology and immunotherapy. And I worked on immunology and immunotherapy of cancer, of pollen-induced allergy, mycological research, and also on hematopoietic stem cells. And today I'll chair the conference. On behalf of the organizing committee, it gives me great pleasure to welcome you to our meeting, the Global Webinar of Immunology, organized by the Global Scientific Teams. Thank you all for attending the conference today. Today marks an enormous event initiated by the Global Scientific Guild, which will provide the opportunity to share research findings and encourage new collaborations to interact in various areas of immunology. Global Webinar on Immunology is a scientific congregation that brings together researchers, scientists, key decision makers, industry professionals in the same physical space for a brief yet intense period of discussions, collaborations, and generation of innovative solutions to address the overarching challenges related to the theme, advances in immunology research, impact on global healthcare. Now, immunology is a very interesting and intricate subject where minute cells wander throughout our body, and also they're placed in strategic portions in strategic points of our body. And hundreds and thousands of scientists are working all over the world to solve the problem of how the immune cells interact amongst each other, how they cross-talk with each other, and also how they secrete the various secretory factors and how they activate the cells and fight against the various pathogens or the cancerous groups of our body. And using immunology as a tool in biotechnological research, we have developed many immunotherapeutic efforts and also many diagnostic tools for the benefit of the humankind. Now, for the immunotherapeutic efforts, we can either boost up the immune system or suppress the immune system, as is required by the various diseases of the body. And today we are very pleased to welcome you to both share and witness advances in this field today. The conference has attracted speakers and delegates from all over the world. I'd like to thank all the speakers and event partners for their continuous support and patronage. The Global Scientific Guild also wishes to thank all the organizing committee members who have put in long hours and generated many creative ideas to bring this meeting together. Finally, we thank each and every one of you, the participants of this conference. We hope you enjoy the conference and that your participation will lead to new ideas, collaborations, and research initiatives. Thank you.
Yes, thank you so much, Professor Swapna, for the introduction speech. I request you to start your talk now. And Professor Swapna Chaudhary is going to give a talk on the immunotherapeutic potential of the novel biomolecule T11 target structure. And I request Professor Swapna to start her presentation.
Speaking on the immunotherapeutic potential of the novel biomolecule T11 target structure, and we'll go back in a flashback mode to state that in a lab, few decades before, we started work with SLBC and have established this as a potent immunotherapeutic agent against cytopenic sarcoma and leukemia induced in mice and brain tumors induced in rats. And these publications authenticate our statement. Now, being inspired from this above notion, we wanted to isolate the immunodominant group of SLPC, which is known as T11PS, or S-LP3 or S-CD58, which ligands with CD2 receptors on the immune cells. But we first established the disease relevance of this novel molecule in our lab. The various functional aspects that has been elucidated have shown the following properties. It works across the interspecies barrier and shown to be effective on mouse, rat, and dog models, and also on human samples in vitro. And it has shown effectivity against ethyl nitrosylvia induced rat glioma, arsenic-induced carcinogenesis in mouse, canine pyoderma, canine generalist pneumaticasis, and human in vitro glioma system, and the fungal infection of Cryptococcus neoformans induced in rats. The bulk of the work was done on glioma, rat glioma, because we know that glioma is the most difficult to treat neoplasm. Therefore, any molecule acting effectively against glioma will act against other neoplasms and other immunosuppressive diseases as well. And in glioma therapy, when the conventional therapies like surgery, chemotherapy, and radiotherapy fail, the molecular therapies are targeted, and the candidate molecule may function in any of the following pathways like immune potentiation, alteration of the cytokine levels, specific apoptotic induction, cell cycle modulation, anti-angiogenesis. And detailed events of the molecular caskets worked out hints at the specific step or steps inhibited by a specific therapeutic agent. And TITS acts as a multi-agent sword intervening each of the pathways to eradicate glioma. But today I'll concentrate on immunotherapy alone, which can be used as an option to remove the minimal residual disease. So we go on for the isolation of this, which was done from sheep erythrocyte by trypsin dilution, followed by ion exchange chromatography. And the third elute has the maximum amount of this, which was selected as the elute of a choice, and it was shown to be a glycopeptide by PAS staining. It was a 253 amino acid long chain, of which 225 amino acid residues from the mature protein, and 193 amino acids were the extracellular domain, and 23 were the transmembrane domain, and 9 were in the intracellular domain. This is the distal adhesion domain of TITS with D1 and D2. And the binding region, the electrostatic binding regions have this structure, while binding of TITS with CD2 in human CD2, rat CD2, and mouse CD2 more or less have the same binding modes with hydrogen bonding. By multiple sequence alignment and phylogenetic analysis of CD58 amino acid sequence from 5 different species like ovine, bovine, suicide, human, and murine, we saw that the binding region is highly conserved because it implies structural and functional importance of the motif. And we also saw that the glycosylation residues remain at the backside of the binding region. And these might play a crucial role for the conformational stability of CD2 binding domain. And it also gives the advantage that later TITS may be used as a synthetic or recombinant therapeutic probe. And also our experimental findings with glycosylated and reglycosylated TIDs, we found that the glycan residues did not have marginal significance. So for in silico trypsin digestion analysis, we saw that there were 21 peptide residues of varying lengths and of varying molecular weights. And mass spectrum of TIDs containing elute fraction 3, we saw that there were multiple peptides and not only one peptide. We also have a patent on the isolation and pharmaceutical composition of TIDs. And now I'll concentrate on TIDs as an immune potentiator against glioma. And I've mainly tried to represent with schematics here. Glioma itself secretes many immunosuppressive agents like IL-10, TGE2, TGF-beta, and granulocytes, which suppress the immune system, forming a vicious cycle so that the glioma can overpower the immune system. At this point, when a TIDs is administered in 3 doses, it potentiates the immune system and the glioma growth is restricted or inhibited. We have induced glioma in 3 to 5 days old rat pups by injecting ethyl nitrosourea at a dose rate of 80 mg per kg body weight. And after 5 months, they have full-blown glioma. And TIDs is injected intraperitoneally in 3 doses at an interval of 6 days at a dose rate of 50 mg per ml. And after each 6 days, that group of TIDs was sacrificed for further studies. Now, to show the functional efficacy of the molecule in histopathological slides, we see that this is the normal blend site with few neurons and few astrocytes and few oligodendrocytes. But after the administration of this, we found that GNU produces grade 4 glioma with plenty of angiogenic vessels. But with the first dose of TIDs, we saw that the hallmark of this reaction was the immunocytes lining the endothelial vessels of the angiogenic vessels, and also the oligodendrocyte membrane was disrupted. With the second dose, there were further infiltration of immunocytes, and the immunocytes showed the kiss of death on the oligodendroglial cells. And also there are very few disrupted oligodendroglial cells left, which are cleared in the third dose when you see the nuclei disrupting from the dead oligodendroglial cells. In the Kaplan-Meier survival curve, we see that the survival rate of the normal rats is 750 days, which is reduced to in between 200 to 250 days in induced rats. But with the 3 doses of TIDs, the survival rates is brought back to normal. Now, we wanted to investigate that how the lymphocytes were potentiated. And we know that when the glioma antigens are secreted, they cross the blood-brain barrier through the breaches into the periphery, and the antigen-presenting cells can present the glioma antigen to the T cells. TCRs gauge the antigens, and this region, this dynamic region, is known as the immunological synapse, where the trimolecular complex is formed. It is attached with CD4 and CD8 tails, and on the 2 sides in the periphery, the CD2 is liganded with the LF3, while on the other side, CD28 ligands with CD8086, and CTLA4 competes with CD20 with 8086 to ligand with CD28. And this area forms the supramolecular complex. And at the periphery, we find CD45. We have studied each and every molecule of the immunological complex because from this starts the downstream signaling. And we have found that all the molecules of the complex were severely depressed during glioma growth, but during TITS administration, there was sequential restoration of the dysregulated components of the immunological synapse, triggering activation of both T cells and macrophages. In effect, TITS mediated corrected T cell signaling through the immunological synaptic proteins serves to assemble a battery of T cells primed to effectively eradicate the glioma challenge. Next, we wanted to study the downstream signaling, which are issued through the immunological synapse, and we have studied the calcineurin NF80 pathway, the MAP kinase pathway, and also the PTC-AKT pathway very intensely with all their molecular aspects. To study the effect of TITS on the CD2 calcineurin pathway, this is the trimolecular complex to which the LCK56 and P59 fin comes closer to phosphorylate ZAP70. ZAP70 then phosphorylates and activates LAT, which forms a platform for the attachment of other adapter molecules like PLC gamma, which is activated to form IP3 and DAC. IP3 attaches to the receptors of the endoplasmic reticulum, releasing calcium to calcium channel, which activates the calcineurin. This activates NF80, which transmits to the which transmits to the nucleus as a transcription factor to release IL-2 and other Thyroid cytokines. So we see that due to the immune suppression, due to the immunosuppressive factors and decreased cytokines, there is loss of T cell proliferation and survival, and down modulation of the CD2 pathway, causing aberrant calcineurin NF80 pathway. But after immunotherapy with TITS, there's upregulation of the CD2 pathway, restoration of the calcineurin NF80 pathway, and augmented T cell survival and proliferation, and enhanced T cell defense against glioma. Next, we studied the MAP kinase pathway. And here we see that glioma inhibits this pathway due to dephosphorylating all the molecules of the pathway like RAS, Turbinate, and PLK, and also CFOS and JUN, the transcription factors. But when TITS is administered, TITS phosphorylates the molecules of the pathway and also activates FOS-JUN, and therefore this is indicative of T cell survival, proliferation, and differentiation, and an immune potentiated state mediated by heightened survival of the Thyroid cells. Next, we studied the AKT pathway. And here we see after activation of TCR and CD28 mediated signals by TITS, the PI3 kinase is activated, which converts PIP2 to PIP3 by phosphorylation. This phosphorylates AKT, and which inhibits apoptosis of the lymphocytes, causing T cell survival. And AKT activates NF-kappa B, which transmits to the nucleus, and therefore there is enhanced T cell survival in rat glioma model. Here, P10 inhibits the PI3, causes conversion of PIP3 to PIP2, therefore inhibiting the phosphorylation of AKT. But TITS also hinders this reaction. Therefore, ultimately, we get T cell survival. Therefore, the highlights of T cell signaling in glioma stated that TIDs induced activation of the T-cell signaling pathway, which operates at multimodal levels, at the level of immunological synapse, at the level of linker and adapter proteins, and also at the level of the downstream signaling pathways. Elevated immune function has been noted at the level of both the T cells and macrophages, so as to rescue T cells from glioma-mediated apoptosis and immune suppression. So what is the result of all this signal transduction? We see that administration of TIDs in 3 doses in ANM-induced glioma in rats causes increased cytotoxicity of splenic lymphocytes when compared to ANM animals. And in each case, normal age-matched animals served as controls in each case. We had heightened phagocytosis of splenic macrophages and also potentiated phagocytosis of splenic PML cells. And in each case, the second dose showed the maximum stimulation, while the third dose brought back the level to the homeostatic level. And when CD4, CD8 ratios were studied, it was shown that from the normal level in the glioma condition, the ratio falls down to below nearly 0 level. But with the administration of TIDs, both in the splenic compartment and also in the brain-infiltrated lymphocytes, the ratio drastically rises to a very high level. Naturally, the cytotoxicity of the lymphocytes drops down to near 0 level during glioma and rises exponentially during the 3 doses of TIDs with the secretion of perforin and glanzin. Microglia is the chief immune modulator of the brain, and we found that with TIDs, there were activation of the microglia with the increase of microglial activation markers like CD4 and CD25 with the TIDs administration, which had dropped down with the ANO administration. And when we studied the cytokine balance, the cytokine balance tilted towards the Hy2 cells during glioma condition, but with the administration of TIDs, this balance tilted again towards the Hy1 cytokines, which of which we have studied IL-12, IFN gamma, and TNF alpha, and gradually the higher up regulation of the Hy1 cytokines causes an environment which is conducive to glioma death. But after the third dose is administered, to bring back the level to the normal homeostatic level, Hy2 levels are slightly increased. This is the level of TNF alpha, how it increases with the TIDs dosing. And now we summarize these reactions I have so far described. That is, as the glioma sheds its antigens and also immunosuppressive factors, it crosses through the breaches of the blood-brain barrier, reaches the peripheral lymphocytes, which are energized due to the immunosuppressive factors, but also due to reaction with the glioma antigen, it becomes specific for glioma. At this stage, when TIDs is administered, this potentiates the lymphocytes, they cross to the nearest lymph node, they cross talk with the APC cells like dendritic cells and the macrophages, and then with the liberation of the Hy1 cytokines, they get activated, they cross the blood-brain barrier, and again, they cross-talk with the microglial cells of the brain, and the lymphocytes offered their cytotoxic hit on the glioma cells, while the macrophages, the microglial cells, and also the activated PMN cells offered their phagocytic hit. So the resultant effect is glioma regression. Then we studied specific apoptosis of glioma cells, and we have studied apoptosis by annexin D assay, BRD ELISA assay, tunnel assay, and the Lager assays. And we have studied apoptosis in the glioma, tumor cells, the brain infiltrating cells, HIL, and the microglial cells. While there was a steep upregulation of the tumor cells and up to about 90% after the drop in ENU level, the microglial cells do not show any turnover, and there is no apoptosis of the bill in the ENU level, but there is slight uprise during the first dose due to the fight with the glioma cells, but it reaches to the minimal level during the second dose. And in the third dose, since it has to restrict the number of lymphocytes in the enclosed cranial cavity, there is also a very slight rise. Then we studied the molecular aspect of apoptosis, both in the extrinsic pathway and the intrinsic pathway. We have studied all the molecular pathways. And we found that all the molecules of both the pathways were activated, excepting BCL2, which was downregulated by the administration of TITs, and ultimately culminating in activation of caspase-3, which was activated to offer the lethal hit to the glioma cells and killing them by apoptosis. So, so far we have seen that during glioma condition, there is desertion of the immune system, and after TITs administration, there is regeneration of the immune system. So we thought that the hematopoietic stem cells might be involved in both the conditions, and there were no such reports of study of hematopoietic stem cells under the glioma condition. And we know that hematopoietic stem cells form the crib of all the immune cells. And when we studied the hematopoietic stem cells, both in the mature and immature and mature compartments from the bone marrow, we have isolated them. And we have seen that there is depression of CD34, C8, and SCA1 during glioma growth, inhibiting self-renewal and lineage commitment. And also the upregulation of angio-1 and type 2 caused increased hibernation of the HSC, causing immune suppression. But during TITs administration, we see the reversal of the effects, and there was rejuvenation of HSC, increased self-renewal, lineage commitment, and increased awakening of the HSC, causing immune potentiation. And we know that there was a myth that HSC cells or the stem cells do not die. But since we saw that there was dissertation of the bone marrow during glioma growth, we have studied the apoptosis of the hematopoietic stem cells by both the extrinsic pathway, intrinsic pathway, and the perforating glycan pathway. And we have studied all the molecules of the pathways, and we have seen that during glioma growth, the HSCs do die by apoptosis severely in all the pathways. And during TITs administration, all the molecules of these three pathways are severely depressed, and hence we find their rejuvenation. Then we wanted to study the WNT and the Notch-JAK pathway during glioma growth to study the effect, how these facilitate effective regeneration of lymphopoiesis by reversing the glycogenic suppression of lineage-restricted progenitor markers. And we saw that both the pathways were again suppressed during glioma growth, so that there was disrupted self-renewal propensity and decreased repopulation activity, and also in the myeloid and lymphoid skewing of mature HSCs were seen, so that there was interrupted production of both myeloid and lymphoid progenitors. And the reverse took place after TIF's administration. There was crosstalk between the two pathways of Wnt and Notch, and there was a synchronized self-renewal propensity, increased repopulation ability, balanced myeloid lymphoid output. And there was coordinate synchrony of myelolymphoid lymphopoiesis in mature HSCs, so that there was increased production of both myeloid and lymphoid progenitors. And then we wanted to study the effect of TIFs on glioma human samples. And we had taken glioma samples from patients of all 4 grades, where meningioma samples were chosen as disease control group. And we saw that in co-culturing with lymphocytes, the cytotoxicity of T lymphocytes of grades 1 and 2 increased, and there was enhancement of the protein perforin and granzyme, suggesting cytotoxic death of TIFs induced target tumor. And TGF-beta secretion in grade 2 and 2 tumors were down-regulated. There was significant modulation of macrophage-associated cytokines, TNF-alpha, depressed VEGF, and the apoptotic protein BAX was increased, BCL2 was decreased, so that there was abrogation of tumor cells when we co-cultured macrophages with the tumor cells of the 4 various grades, and also we found increased phagocytic potential. So to summarize the immunotherapy of brain tumors with the novel molecule TIFs, we can summarize them as saying that brain tumor immunotherapy with TIFs not only stimulates the peripheral immune system, but also the cranial immune system, which culminates in causing apoptosis of glioma cells, but rejuvenates the lymphocytes, which can be fortified for glioma killing. Further, it can also potentiate the hematopoietic stem cells, the peak of all progenitor immune cells, so that the immune cells are regenerated in large numbers to nullify the glioma-associated catastrophe of the immune system. Immune augmentation not only specifically apoptosizes the neoplastic cells, but will also protect the secondary infection of cancer patients with and without conventional therapies. Of the conventional therapeutic agents in use for glioma abrogation, targeted therapy against glioma not only destroys the tumor, but harms adjoining normal tissue areas, causing systemic impairment and brings about profound immune suppression. Unlike those agents, TIFs, however, not only aids glioma apoptosis, but also supports lymphocyte survival and proliferation. This is a major therapeutic advantage of this molecule. We next studied toxicity studies with TIFs, whether it produces any toxicity. We have studied both the acute and subacute toxicity of TIFs, and we followed the Appendix 3 of Schedule Y of Indian Drug and Cosmetics Act. In both in the acute toxicological studies and the subacute toxicological studies, we found that there were no toxic effects of TIFs. And then we went on to another subject of effect of TIFs on arsenic-induced carcinogenesis in mice. Here we have induced carcinogenesis by using arsenic as a promoter and using ENU as a carcinogen. And in the experimental approach of the study, it indicates that TIFs acts as an immune potentiator and counteracts lymphocytic death after arsenic-induced neoplastic state. MIA-DMSA, which is an chelator of arsenic and an antioxidant, was used for arsenic treatment, but it caused enhanced lymphocytic death with 5-1 cytokine upregulation. Hence, though MIDMSA is an effective chelator, it may not be an ideal candidate for combination therapy with TIFs for arsenic intoxication. But when we used TIFs alone in 3 consecutive doses, we found more beneficial effects in reversing the immune suppression towards arsenic, towards a normal state. Then we studied the effect of TIFs on canine diseases. Here we see that canine pyoderma and the causative agent was Staphylococcus intermedius. The normal antibiotic regime was ciprofloxacin. And then we used a regime of TIFs as an adjuvant immunotherapeutic molecule, which showed maximum recovery as compared to diseased dogs and dogs receiving the antibiotic alone. And also we studied the effect of TIFs on Demidocosis canis. And Demidocosis canis is a natural inhabiting mice of the canine skin. Amitraz is the acaricide used conventionally for the treatment of TIFs, treatments of Demidocosis. And two immunorestorative drugs like Immunoplus and TIFs were used as along with Amitraz. And it was observed that Amitraz treated groups responded to the therapy, but the groups treated with immunotherapeutics like Immunoplus and TIFs responded better. However, the group treated with TIFs showed the best result. Then we studied the effect of TIFs on Cryptococcus neoformans, and this was an extensive study. Here we see the normal lung and the C. neoformans infected lung. Here we can see the C. neoformans. But with 3 doses of TIFs, we see the clearance of the total clearance of the fungal body. And the CFU count of fungus in lungs and spleen after 7 days of infection, we see that after the 3 doses of TIFs administration, there was total clearance of the fungal body. And this was also supported by the GXM levels in the treated groups as compared to a normal group. And then we studied the immunotherapeutic role of TIFs on the adaptive immunity of T cells. And we saw that there was positive regulation of the immunological synapse molecules of T cells, which are augmented, but CTLA4 was downregulated, and there was rejuvenation of the calcineurin NFP signaling pathway, enhanced IL-2 secretion, indicating greater proliferation and activation of T cells, skewing of Thy1, Thy2 cytokine meaning towards Thy1 arm. Fast facets were diminished in TIFs group, indicating survival of both components of T cells, with the increase of perforin granzyme in both component of T cells were augmented, suggesting increased cytotoxicity of thin neoformans. Tregs and associated markers were diminished with lower IL-10 and TGF-beta, and Treg-associated perforin granzyme expressions were augmented. These are the publications establishing the above. And then when we studied the innate studies of against Cryptococcus neoformans with TIFs, we found that toll-like receptors and its downstream signaling cascades in macrophages were highly upregulated with the upregulation of pro-inflammatory cytokine and chemokine. The phagocytic markers like CD11B and CD18C and CD206 were upregulated, indicating higher phagocytosis, and ANO favored the heightened expression in immunotherapy groups, and also there was decreased expression of superoxide dismutase and catalase in immunotherapy group, favoring the diminution of diseased condition, and the antigen presenting capacity of macrophage and microglia were increased. And TIFs also act as specific apoptotic inducer, facilitating clearance of the Cryptococcus infected macrophages. And it also activated the innate immune NK cells by increasing their perforin granzyme secretions, and also critically regulated the balance between Thy1 and Thy2 cytokines. So to summarize, we can see that immune augmentation not only specifically apoptosizes the neoplastic cells, but will also protect the secondary infections of cancer patients with and without conventional therapy. TIDs can be used against immunosuppressive diseases in veterinary science and also in exploration in clinical trials. The isolation and application of TIDs has been patented. Toxicological studies conducted with TIDs has proved to be non-toxic. So we are waiting for TIDs to reach from bench to bedside. These are my fighters, my students, who have made my dream come true. And these are the various funding agencies who have supported the studies. And I'd like to thank you and the sheep who has donated its blood all through would like to thank you on my behalf for your kind attention. Thank you.
Thank you, Professor Swapna Chaudhary. That was a really excellent presentation. Thank you so much for the presentation.
Thank you.
And we are open to questions now. If anybody has a question, please ask Professor Swapna Chaudhary. And our next speaker for today is Dr. Litzke Marco from Helios Clinic, Germany, and he's going to give a talk on autonomic balance determines the severity of COVID-19 curses. And I request Dr. Marco to start his presentation. Yes, please continue.
First of all, I want all of you to thank for your attention of the seminar. And in opposition to the presentation shown before, our goal goes to investigate how immune reaction can be limited. And our group has been dealing with this issue for several years. And concerning the current pandemic, we started investigating the meaning of the autonomic balance to the severity of COVID-19 causes. And now I'm going to report about a hypothesis paper recently published in Bioelectronic Medicine, and I hope you will enjoy it. The paper is entitled Autonomic Balance Determines the Severity of COVID-19 Causes. And as you all know, the SARS-CoV-2 virus shows broad genetic similarities with other coronaviruses. The mean difference to the known coronaviruses is that its affinity to the cellular angiotensin converting enzyme receptor is tenfold higher, which in the consequence explains the high contagiousness and the immediate improving to pandemic within a few months. This explosive spread lately caused the WHO to declare public health emergency of international concern. And as we all know, the consequences of the major threat to our healthcare systems has a distinctive meaning for the economic and social systems, and moreover, of course, for the individual cases. So the symptoms, as we all know, are most widespread. They can range from mild disease causes with kind of like a flu or influenza-like symptoms, and can grow up to acute respiratory distress syndrome, liver damage, severe intestinal dysfunction, rhabdomyolysis, acute renal failure, severe coagulopathy with hemorrhagic embolism, stroke, or seizures. In all the cases we saw with severe causes of COVID-19, we saw high elevated pro-inflammatory interleukins, as for instance interleukin 1 beta, interleukin 6, interleukin 8, or TNF alpha. And the extent of their hyperexpression had severe meaning for the prognostic situation, so that many authors speak about the hyperinflammatory syndrome or cytokine storm. And we know that the viral spike protein is the center of the adherence to the ACA2 receptors in the susceptible cells. And important is that this S protein has to be proteolytically primed by transmembrane protease serine subtype 2, which is highly concentrated on the epithelial cells of the respiratory tract and allows them to fuse with the coronavirus and the cell. The cleavage of these cells is promoted by TRMPRSS2 and leaves the virus to enter endosome-independent the cell. And just because of this tropism, SARS-CoV-2 yields very high replication rates in the cells of the upper airways and the pulmonary inflammation sites, which lately shows in the primary effectors of the lung. Sorry. Concerning the immune response, we know that especially the cells of the upper and the lower airways are able via monocytes, macrophages, and dendritic cells to release cytokines along coronavirus infections. And that SARS-CoV-2 RNA presents a pathogen-associated molecular pattern in those cells, which as a consequence is recognized by so-called pattern recognition receptors, for instance, toll-like receptors, which in turn are severely involved in the NF-kappa B2 activation, which subsequently leads to improved downstream release of NF-kappa B dependent cytokines. NF-kappa B is a transcriptional factor for several proteins, especially pro-inflammatory cytokines, but as well pro-coagulatory or antifibrinolytic proteins, which is later the matter. Despite accelerating the NF-kappa B pathway, the pump recognition and damage associated molecular patterns, the DAMs, lead to inflammasome assembly, which is a mechanism which leads to further improvement of inflammatory cascades. Inflammasome under normal conditions promotes the clearance of pathogens and damaged cells and leaves the cell without a burden of damaged cells or pathogens. Interleukin-1 beta is a principal mediator of systemic inflammation, and it takes part or is involved in the induction of the expression of a large amount of pro-inflammatory genes, and it acts on numerous target organs. Furthermore, it is supposed to cause the additional release of other pro-inflammatory cytokines like interleukin-6, interleukin-8, and TNF-alpha. Additionally, interleukin-8 drives chemotactic migration of additional inflammatory cells, which promotes the perpetuation of the inflammatory process. Nevertheless, the cytokines of the EL1 family cause fever and inflammatory fibrotic conversion of pulmonary stroma, which causes severe damage to pulmonary tissue, which is summarized as diffuse alveolar damage and characterized by diffuse thickening of the alveolar wall, forming the hyaline membrane, which severely compromises the oxygenating function, the respiratory function. And also seen was that the vasculature of the lungs showed a severe endothelial injury with disrupted cell membranes. Moreover, pulmonary vessels in COVID-19 severe cases showed widespread thrombosis with microangiopathy. And all these mechanisms taken together represent the dramatic pulmonary tissue damage which we see in the cases with severe COVID-19, which almost to be described as a drama itself. In this CT scan, we can well describe the problem of the consolidated lung. We see widespread disseminated infiltrations and consolidations of lung, which make it clear even to people never deal with CT scans that this lung is very hard to ventilate, or the respiratory function of this lung is hardly compromised. Moreover, the cytokine storm-related interleukins like IL-6, IL-1, TNF-alpha are involved in inhibiting myocytic membrane channels, which in the end leads to prolonged QT times with concomitant ventricular arrhythmias. And this cardiac involvement is significantly contributing to the multi-organ dysfunction. The cause of the dysfunction in several other extrapulmonary organs consisting of tissues with low or no ACE receptors mentioned above remains quite unclear. It could be attributed to direct virus attack, or like our group thinks, more likely to the locally and systemically impaired tissue oxygen supply due to the specific COVID-19 associated coagulopathy with major thrombogenesis and resulting ischemia and tissue damage. The CDC declared the preconditions for severe, for expectable severe disease course of COVID-19, and the question arises when we see pulmonary disease like asthma or chronic pulmonary disease. We see kidney injury, we see metabolic diseases, we see immunocompromising diseases, liver disease, age is but on the other hand, we know that there is extrinsic autonomic dysfunction due to the hypersympathetic ANS adaptation to organ dysfunction. And on the other hand, we know the intrinsic autonomic dysfunction, which is in the most cases diabetes related due to the diabetes related damage of vagal nerve axons. Since 2002, we, in the honorable work of Mr. Kevin Tracy and Mrs. Borovikova, we know the cholinergic anti-inflammatory pathway, which describes that after tissue injury, despite cytokine release, there is afferent vagus nerve signal which is conducted to the dorsal-vagal complex, and there is processed and in the end leads to afferent vagus nerve signaling in a somatotopic manner, which means that brain-standing and alpha-7 acetylcholine receptors are blocking the cytokine release via blockade of the NF-kappa B pathway, because NF-kappa B is the center for the synthesis of the pro-inflammatory cytokines, and this way circuit is promoted, which controls cytokine release which controls innate immune response without host damage and otherwise effective defense against any kind of external assault. One can imagine that within a disbalanced vagal system or autonomic nervous system, that this circuit is severely compromised and that the cytokine release can be compromised as well. We should mention that the spleen, as the principal source of the pro-inflammatory cytokines, is able to amplify the cytokine liberation up to systemic cytokine storm, and that it's one of the top targeted organs from the CAP, and it's essential for CAP functionality. All these facts taken together, we know that we can imagine that control cytokine release is linked to well-balanced autonomic nervous system, and that controlled pro-inflammatory cytokinic response to SARS-CoV-2 invasion appears quite unlikely in patients with aforementioned pre-existing conditions. What's the job of, or what's the performance of coronavirus concerning the NF-kappa B pathway? We know that the NF-kappa B pathway is the replication site for coronavirus, or the replication transcriptional factor for coronaviruses as well. Under normal conditions, the cytoplasma is filled with so-called pre-existing subunits of NF-kappa B. We know the non-rel subunits and the rel subunits, and they have to be one non-rel and one rel subunit have to find together to form major NF-kappa B. Within the cytoplasm, they are bound to inhibitor proteins, just preventing their unrestricted passage to the nuclear membrane. And so NF-kappa B homeostasis is generated. If there is any assault, the NF-kappa B pathway is started with the proteolytical degradation of these inhibitors, these inhibitors of kappa B, which prevent the passage of the subunits to the through the nuclear membrane. When the coronavirus invades the cell, it activates the so-called E-kappa B kinase complex, EKK, which is followed by proteasome-derived proteolytic degradation of E-kappa B. This in turn leads to nuclear translocation of NF-kappa B subunits and uncontrolled NF-kappa B formation. The virus-driven replication leads to NF-kappa B-driven virus replication, and cytokine synthesis are accelerated and go together in this stage. Therefore, we can conclude that inadequate vagal representation is the cause of both unrestricted virus replication and uncontrolled cytokine release along the viral hijacked NF-kappa B pathway. This is the key picture of our presentation. Here is described the performance of the SARS-CoV-2 virus as it invades via the ACE2 receptor, the cytoplasm, and additionally it promotes the activation of E-kappa B kinase complex and the proteasome, which both lead to the degradation, proteolytic degradation of these inhibitors, and set these subunits, non-rel and rel subunits, free to cross the nuclear membrane and to form major NF-kappa B. And one can imagine if this process happens unrestricted, then we have very, very pleasant conditions for the virus to replicate, and moreover, the cytokines, the pro-inflammatory cytokines, interleukin 6, interleukin 8, and TNF alpha are hyper produced as well. Sorry. In this situation, one can imagine that the vagal nerve representation within the autonomic nervous system plays a major role. And if this system, this autonomic nervous system, is compromised to the treatment of the vagal axis, that this control is compromised as well, and then the NF-kappa B production is almost unrestricted with its consequences described before. Kevin Tracy did not only describe the cholinergic inflammatory pathway, he showed in several cases that vagal nerve stimulation can rebalance this disturbed autonomic nervous system, restore autonomic balance, and which finally leads to better control of NF-kappa B action, which was shown by Guarini in a work 2012, I guess, and in a control of cytokine release in several different diseases. It was shown this vagal nerve stimulation is able to yield very good results, as for instance in treatment-resistant anxiety disorders, in the management of coronary heart disease, in depression. One must say that all these incidences are connected with high pro-inflammatory cytokine levels, so that the approach via vagal nerve stimulation is quite reasonable. It was shown for diabetes. Vagal nerve stimulation was shown to be effective for the treatment of heart failure, treat morbid obesity, to renal injury, rheumatoid arthritis. The rehabilitation results after ischemic stroke were fairly better than without vagal nerve stimulation. And so one can summarize that we speak about cardiovascular diseases, neurological disorders, addiction, hyperinflammatory diseases, metabolic disorders, and most of all, to be expected for the mankind, even xenophobia should be healable. Mr. Lehrer and Mr. Gewitz showed that despite except vagus nerve stimulation, so-called biofeedback mechanisms are capable to stimulate the vagal axis as well, and they showed that with a breathing frequency of 0.1 hertz, a strong augmentation of vagal nerve signaling is achievable, which in the end means breathing 5 times per minute leaves very strong vagal nerve stimulation. In our results, we showed that via the electrical stimulation of the gastric wall leads as well to vagal nerve stimulation. The sympathetic vagal balance can be analyzed with heart rate variability, and if heart rate variability is divided under the domain frequency, one can see that this part is the sympathetic branch in the so-called low frequency range, and without stimulation we see in the high frequency range no real signal, and after gastric wall stimulation we could show that the vagal activity is strongly improving, and sympathetic activity is slightly decreasing. With this short overview, I hope I could give you, I could attract your interest for the theme of vagal nerve stimulation. Thank you for your attention and wish you a pleasant day further on. Thank you.
Thank you, Dr. Marco. Thank you for your excellent presentation. Thank you so much. Yes. And we are open to questions now. If anybody has questions, please ask Dr. Marco.
Thank you.
Yes. Okay, and moving on, our next speaker is Dr. Klimo Andrew from Siberian State Medical University, Russia, and he's going to give a talk on a decrease in serum serotonin concentration in logical allergic rhinitis. And I request Dr. Klimo Andrew to start his presentation.
Hello, else, my colleagues. May I begin?
Yes, please.
Okay. Dear youth, for your attention, I present you some results of my science job in presentation. Now you see another title of my presentation. In my old abstract was the title as a decrease in serum serotonin concentration in local allergic rhinitis. But now it has another title, an extremity disorder as a comorbidity in local allergic rhinitis. This is Siberian State Medical University. I am an assistant professor in the Siberian State Medical University, and I dropped in 2 chairs, Immunology chair and also a chair of ENT diseases. Okay, next. Abstract. Aim of my job. It is a differentiation the endotypes in allergic rhinitis by key allergy markers in the mixed patients group. Material and the methods. There were studied 48 patients, males and women, 18 and 60 aged, suffering from 2 endotypes of allergic rhinitis, conventional and local. The standard diagnostic of allergic rhinitis included a patient history, family history, video rhinoscopy, allergic skin tests, to house dust, mite, and nasal provocation tests, NAPT. Those allergens, and serum total IgA concentrations. Additionally, there was investigate the Oxynti questionnaire by Spitzel and another. Statistical non-parametric analysis were carried out using statistic 17. Qualitative parameters, allergic skin tests, SNAP, questionnaire answers were exploited in correlation analysis. Results. The common group was divided in 2 subgroups. These high IgE concentration and low IgE. The first subgroup include 22 patients, and the second subgroup include 26 patients with low IgE. Almost all patients in each subgroup had conditional characterization of the skin allergic test positive in the first group and negative in second group. Conclusion. This data promotes a new resection trend of allergic rhinitis endotypes, including neuroimmune crosstalk when allergen tolerance breaks down. Introduction. Over the last decade, a new allergy-like phenomenon has been identified to entopy, and the term came from the Spanish expressions entopo, that meant on site. Interestingly, the entopy almost sounds like ENT, ear, nose, and throat, ENT organs. In the beginning, the new phenomenon was not related to atopy. Eventually, the local allergy referred to an atopic disorder, which can develop into local allergic rhinitis. Also dual allergic rhinitis, also local allergic conjunctivitis, and local allergic asthma. We suppose that analogs to any form of atopy, local atopy is associated with allergen tolerance breakdown, but process autonomous usually of the specific anatomical site, nasopharynx, or even untied airway, involving not completely clear mechanism. The objective of this research is to differentiate the clinical peculiarities and comorbidities of local and conventional endotypes. The first picture. In this picture, you see two photo from video rhinoscopy. Video rhinoscopy is a conventional, in conventional types, it is rhinoscopy A, picture A, and picture photo B, it is rhinoscopy picture. Has patient with local rhinitis. There are edema and cyanosis in the field of inferior turbinate, no difference. At first, photo A, it is a video rhinoscopy. This is unconventional rhinitis. You see, this is turbinate, nasal turbinate inferior. It is a nasal cavity. It is the nasal turbinate inferior. This is nasal turbinate media. This is septum, septum nasal. It is a right part of nasal cavity. And this is meatus, nasal meatus media, and this is nasal meatus inferior. But now we must pay attention on the inferior nasal turbinate. Inferior nasal turbinate. These local allergic rhinitis and the system allergic rhinitis or conventional allergic rhinitis. There is no difference between nasal turbinate inferior. In both cases, nasal turbinate inferior has edema and cyanosis. Next, also I investigate total IgE to dipterocyanosis in classic allergic rhinitis and local allergic rhinitis. This is local allergic rhinitis and this is classical allergic rhinitis. In comparison, this local allergic rhinitis, the allergen tolerance breakdown in classical allergic rhinitis results in an essential increase in serum total IgE. Also, we investigate nasal breath. They use a special equipment to investigate nasal breath. This investigation named anterior active rhinomanometry. And you see it in the picture. Nasal progression, nasal path is useful for discrimination allergic, non-allergic, and local allergic rhinitis. Unlike the bronchial tract, the nose is very accessible. Contraindications to NPAT are acquired bacterial or viral rhinosinusitis, exacerbation of allergic rhinitis, history of anaphylaxis to allergens, any defects of the perforated septum. Severe general disease, several forms of application are possible depending on the allergen formulation, application site, and mode of application. Rhinomanometry. The rhinomanometry, it is a form of manometry used in the evaluation of the nasal cavity. Rhinomanometry, it is a standard diagnostic tool to objectively evaluate the nose respiratory function, pressure and flow during normal inspiration and expiration through the nose. Increased pressure during respiration results from increased resistance to air flow through nasal passages, nasal obstruction, while increased flow, which means to speed of airstream, is related to beta patency. Nasal obstruction leads to increased levels of nasal air resistance. I think in this picture, but this photo is bad for this photo. This is this is flow. It is right part of nose and it is left part of nose, and this this is flow, air flow, and this is pressure. Next, in some approaches, the interpretation of response to an path is based exclusively on the symptom score: rhinorrhea, obstruction, itching, and sneezing. In others, the active anterior rhinoscopy is exploited to evaluate the assessment of nasal airflow. Sorry, it is mistake, rhinomanometry. Rhinomanometry is used to assess nasal resistance by measuring airflow and at specific pressures. It calculates the difference between external pressure and pressure in the nasal choana by means of a pressure guide and a flow rate per time unit being 2 points. The rhinomanometric examination served to analyze a nasal airway resistance for the flow rates. Measures in the right and the left nasal passage separately during normal breathing. The early phase of the allergic reaction was accessed. To avoid the risk of the allergen in the lower airways, the use of assess every 15-30 minutes after application. Also, the possible occurrence of a delayed reaction with new symptoms hours after the test concludes should also be taken into consideration. False negative path results may be due to the use of contraindicated drugs, nasal surgery in the previous 8 weeks, atrophic rhinitis, and allergen-specific immunotherapy. To avoid the risk of depositing the allergen in the lower airways, they use a micropipette and small amount of solution is preferable. The bilateral application is considered to be more physiological. In parts, thus, this application of an inert substance. The test proceeds with a serial application of differential concentrations at intervals 15-60 minutes, depending on the patient's sensitivity. Nasal response can be assessed every 15-30 minutes after application. False negative part results may be due to use of contraindicated drugs. Nasal surgery in the previous 8 weeks, atrophic rhinitis, and allergen-specific immunotherapy. This is parameters of anterior active rhinomanometry. It is summary nasal resistance and summary flows for right and for left part of nose. About allergen nomenclature. Allergens are T-dependent environmental antigens which are capable triggering B-cell mediated adaptive response with perfectionally IgE productions in atrophic individuals. Minor allergens except the high immunogenicity, whereas the minor allergens have the weak ability to IgE immune response. The allergen nomenclature based on the first linear binomial nomenclature identifying gens and species and modern advance in both sequencing and bioinformatics and abbreviation of scientific name of allergen source, including gens, 3 letters, and species. Follow the first. For example, DRP means an allergen from house dust, mite, Phagoideus pteranissimus. Next are the character which is related to both sequencing and bioinformatics may follow. This is an allergen nomenclature. Next, how to read allergic skin test. Oh, I show you type about hypersensitivity. Type 5, it is early phase 20 minutes, late phase for 6 hours. Type 4, 48 and 72 hours. You see degrees. And also about allergic skin tests, we used a special form. Next, what about the aim? What about the anxiety disorder? Also, they use this method about it is a Spritzer 2002. We investigate an anxiety disorder by this special method. I show you. Patient answer special questions. This is 70 special questions, and by his answer, they investigate a degree of anxiety disorder. It is a correlation analysis. For example, it is allergic test, skin test, and also bronchial asthma, also food allergy, and anxiety disorder. And we see about allergic skin tests about persons, and also anxiety disorder. In second subgroup, this local allergic rhinitis, anxiety disorder is decreased. Then in the first group, this classic allergic rhinitis. We propose as a hypothesis to be tested that the mono's allergen tolerance breakdown in the nose may be caused by an imbalance of immune upregulating and immune downregulating neurotransmitters. Then the concentration of inhibitory molecules is lower than the normal nasal level. The neurotransmitter imbalance paradigm seems to be among possible explanation of the local allergic rhinitis pathogenesis in atopic predisposition, but requires a further study and discussion. Conclusion. The difference in the allergen tolerance breakdown in conventional allergic rhinitis and local allergic rhinitis remains unclear. Meanwhile, the purpose of all routes is of acid in atopic disorders, including rhinitis, is allergen tolerance restoration. Besides, the choice of route of allergen administration may be critical for acid efficacy. Therefore, various proper combinations of different routes of acid and medication treatment plus physiotherapy to become efficient in atopic entities should be sub-tented depending on the mechanism of allergen tolerance breakdown. Thanks for attention. It is all. It is all. Thanks for attention.
Yes, please continue. And moving on, our next speaker is Dr. Jakob Matai from Marma Health Center, India, and is going to give a talk on fever is not a symptom in COVID-19. None of the diseases require fever as its symptom. Dr. Dr.
Okay, I am ready.
Jakub
I
Matai to
want
start his presentation.
Yes, okay. I am ready. I want to share my screen.
Yes, please. Yes. Please start your presentation.
Yes. Okay. I am Jakub Matai from Kerala, India. Today, I want to discuss with you. The subject is fever is not a symptom of COVID-19. None of the disease require fever as its symptom. We have been hearing for centuries that fever is not a disease but a symptom. All the studies related to fever as a symptom of a disease have been done without knowing the purpose or temperature of fever is. In the current COVID-19 epidemic situation, it has great importance because fever is considered as a symptom of COVID-19. Not knowing the purpose or temperature of fever, how can fever include as a symptom in COVID-19? In COVID-19, up to 86% of patients have no fever. Why up to 86% of patients with the SARS-CoV virus have no fever? That is a question. Is it because there is no need for the care of fever, or is it because the disease is free of symptoms? Most of the disease may not have fever. Sometimes it disappears. Then is fever a symptom of which disease? That is a question. Another question is the temperature between 38 to 41 degrees centigrade can be a symptom of a disease? What is the use of symptom definition? As any or all other definitions, symptom definition should be describe the symptom scientifically. If it cannot describe it clearly, there is no use of a symptom definition. Symptom definition is the only parameter necessary for a symptom. Symptom definition. A symptom is a departure from normal function or feeling, which is noticed only by a patient, indicating the presence of disease or abnormality. A symptom is subjective, observed by the patient, and cannot be measured directly, whereas a sign is objectively observable. A symptom can more simply be defined as any feature which is noticed by the patient. A sign is noticed by other people. Not even a single trace of symptom definition can be seen in fever definition, and vice versa. A symptom has no ability to make other actions. During fever, sponging with the water is used to reduce temperature, then shivering takes place to produce heat. Shivering is a heat-producing action. An action can never become a symptom. Elevation of body temperature is an action like lifting, sitting, or standing. Is elevated temperature a scientific criteria or parameter or symptom? No. The patient cannot feel elevated body temperature. According to symptom definition, fever is not a symptom. Then what are the criteria to assess a symptom? That is a question. Nobody knows. Then which scientific basis can fever be considered as a symptom? Nobody knows. If elevated body temperature is not a symptom, then what? One cannot understand directly the temperature is elevated in the hypothalamus. A mechanical device is necessary to measure elevated temperature in the hypothalamus. According to sign definition, it is a sign. Then arises another question about body temperature. If elevation of body temperature is a sign, then which category will temperature of fever come under? Signal category, like a traffic signal. Everybody can feel. No device is required. Elevated temperature or increased temperature never make a fever or symptoms of fever. Different cause of disease never make same symptoms. Different cause of disease like virus, bacteria, fungi, venom, parasin, and horridry never shows same symptoms. Its actions are different, sometimes opposite. No similarities can be seen between their actions. The symptoms of virus, bacteria, and venom are not based on fever. All the symptoms and the signals of hypothermia can be seen in fever too. That means there is a common basic science behind these phenomena. None of the disease or cause of disease require fever as its symptom. Patients who have flu to cancer may not have fever. The symptoms, signs, signals, and of fever are only seen at the presence of fever. If fever is symptom, one symptom has no ability to make other symptoms. Fever makes numerous symptoms, signals, and actions, etc. If fever is symptom, we cannot call a person as a fever patient. If fever is symptom, no treatment is required to reduce fever. Treatment is required only for disease and its cause. Our immune system never increase elevated the symptom in the hypothalamus. A symptom can never cause fatal. We can prepare a table showing symptoms, signs, signals, and actions of disease, fever, and rising temperature. This table is known as Jacob's table showing symptoms, signs, signals, and actions of disease, fever, and rising temperature. How can we separate fever from fever condition? Fever condition include both disease and fever. If we deduct disease from fever condition, we will get the fever. So we can prepare an equation to separate fever from fever condition. This is another table also. Jacob's equation of separating fever, hypothermia, and disease. Table number 1. Fever equal to fever condition minus disease, lack of fever. How can we separate hypothermia from hyperthermia condition? Hyperthermia condition include both disease and hyperthermia. If we deduct a disease from hypothermia condition, we will get the hyperthermia. So we can prepare an equation. Table also available. Counter checking also possible. How can we separate symptoms of disease and symptoms of fever and symptoms of hyperthermia? A fever condition means symptoms, signs, signals, and actions of both the disease and fever are included. A hyperthermia condition means symptoms, signs, signals, and actions of both the disease and fever are included. We can separate symptoms, signs, signals, and actions of fever and hyperthermia and disease. This is a table. There is a sharp difference between symptoms of fever and symptoms of rising temperatures. Symptoms of fever include body pain, bitter taste, fatigue to mind and body, reduced appetite, reduced motion, hand indigestion, and aversion towards cold substance, internal external discomfort, etc. If symptoms of fever are mentioned above, how can fever be a symptom? That is the question. Symptoms of rising temperature include likeness towards cold items, like to drink cold water, feel discomfort while using blanket, feeling hot, etc. If symptoms of rising temperature are mentioned above, how can rising in temperature be a symptom? That is the question. Fever never shows symptoms of rising temperature. This is a table, Jacob's table showing symptoms of disease, fever, and rising temperature. Table number 2. Symptoms of fever is left side, symptoms of rising temperature is middle, symptoms of disease is right side. The equation also in the symptoms of fever condition, how symptoms of fever can be measured. Symptoms of fever equal to symptoms in fever condition minus symptoms of fever. Symptoms in fever condition, both symptoms of disease and symptoms of fever are included. So we can deduct symptoms of disease from total symptoms of fever condition. We will get symptoms of fever. Symptoms in hypothermia condition, both the symptoms of disease and symptoms of hypothermia are included. If we deduct symptoms of disease from total symptoms of hypothermia condition, we will get symptoms of hypothermia. So we can prepare an equation. Of course, the table showing signals of disease, fever, and rising temperature. Table number 3. Signals of table are signals of fever is shrunk blood vessels and skin, shivering, increased sleep, temperature rise between 38 to 41 degrees centigrade. Signals of rising temperature, expands blood vessels and skin, and body septs, decreased sleep, and increase of temperature. The pressure will also increase, uncontrolled high temperature, etc. Signals of disease, fits, unconscious, delirious, color and smell of urine and stool will change according to disease. Jacob's equation separating signals of disease, fever, and hyperthermia from fever condition, hyperthermia condition. Signs in fever condition, both the signs of disease and the signs of fever are included. So we can prepare an equation. Signs of fever condition equal to, first I told you, The table showing signs of disease, fever, and rising temperature. Table number 4. Signs of fever. The firing rate of W neurons decreases and the firing rate of cold sensitive neurons increases. Increase of prostaglandin, etc. Signs of rising temperature. The fire rate of warm sensitive neurons increases and the fire rate of cold sensitive neurons decreases. Signs of disease. Numerous signs like pressure decreases and increases, blood circulation decreases. Equation of separating signs of disease, fever, and hypothermia from fever condition and hyperthermia conditions. Signs of hypothermia condition, both the signs of disease and the signs of hyperthermia are included. So we can prepare an equation. According to table, actions of disease, fever, and rising temperature. Table number 5. Actions of fever. Temperature rise between 38 to 40 degrees centigrade. TNF alpha cause bitter taste to food and etc. Actions of rising temperature. Blood circulation decreases to brain and other organs. Loss of fluid due to dehydration. Actions of disease. We can see numerous actions according to disease and cause of disease. Equation of separating actions of disease, fever, and hypothermia from fever condition and hyperthermia conditions. An action, okay. In fever does not show any actions of hyperthermia. That's the most important point. After analyzing and evaluating the above tables and correlating them, it becomes clear that what is right and what is wrong. In physical appearance, fever is a warning signal. Tomorrow I have another paper. I will discuss it in thoroughly next day. A new fever definition diagnosis treatment is required. How can we prove fever is not a symptom in COVID-19? The fever is not a symptom in COVID-19 when examined in various directions. We can separate symptoms of fever and symptoms of disease and symptoms of rising temperatures. Like that, we can separate signs, signals, and actions of fever and disease and rising temperature. If we ask any type of question related to fever by assuming that fever is not a symptom in COVID-19, we will get a clear answer. If we avoid or evade from this, we will never get a proper answer to even a single question. If we do any type of treatment by assuming that the fever is not a symptom, the body will upset. At the same time, body will resist whatever treatment to decrease blood circulation. Besides that, we use symptom definition. No further evidence is required to prove the fever is not a symptom. Benefit of timing the fever temperature as a signal. The purpose of definition of signal is to analyze the signal scientifically, to differentiate and also to brief it and understand it easily. If we say there exists temperature as a signal, one can easily understand without much explanation. In such a situation, automatically comes apt word as well as apt definition. That is why it is told to exclude the temperature of fever from symptoms of the disease. Conclusion. Fever is not a symptom in COVID-19 when examined in various directions. Temperature between 38 degree and 41 degree cannot be a symptom of any of the disease. None of the disease or cause of disease require fever as a symptom. A different cause of disease like virus, bacteria, fungi, venom and horror and horror drain never shows the same symptoms. Opposite disease never shows same symptoms. Fever has never been scientifically proved as a symptom of disease. Fever has the properties of adaptation. Fever treatment should be revised according to the warning signal of a disease. A new fever definition, diagnosis, and treatment is required. It is wonderful that a physician having years of experience in fever treatment cannot understand actual fever definition, and fever treatment have no relation with symptom definition and diagnosis. In the early days of my discovery, I thought that fever is a symptom of disease. I never got any answers for even a single question about symptoms. That induced me to find out the real truth of fever. I can eliminate conservative fever definition, diagnosis, and treatment. If you discard discovery, it would be an injustice to mankind. I also prepared 8,000 affirmative cross-checking questions, which can explain what queries related to fever. The real signs of fever can be termed as the physics of fever. Thank you. Hear me patiently so far. This paper is published in a journal. I already shared the link of the journal. Please check your inbox. If you have any questions, you can ask to personally. You can ask to my WhatsApp number and my email number also. Hello.
Yes, yes, Dr. Yakub, we can hear you.
Okay. Any questions? Tomorrow I have a paper about the purpose of temperature of fever in COVID-19. Then you can discuss, I can share all the details about the fever.
Thank you. Thank you so much, Dr. Yakub. It was really informative on the COVID-19 situation right now.
Okay, welcome.
Yes. We are open to questions. If anybody has a question, can ask Dr. Yakub. Are there any questions? I request
Hello,
Frika to
everyone.
start her presentation.
Okay. Hello, everyone. I'm Dr. Fetan Frika, professor in internal medicine from Medical University of Tunisia. I'm happy to participate in this webinar today. We will be discussing antiphospholipid syndrome. Let's start with the definition. It's a rare occurred autoimmune disorder characterized clinically by recurrent venous or arterial thrombosis and or fetal loss, and biologically by the presence of persistently elevated levels of antiphospholipid antibodies. In clinical practice, knowledge about diagnosis, clinical spectrum, and management is continuously advancing. Until now, the Sapporo criteria are usually recommended for the diagnosis of antiphospholipid syndrome. They include the presence of one clinical criterion, thrombosis, arterial, venous, or small vessel thrombosis, pregnancy-related morbidity, and the presence of high values of at least one antiphospholipid among lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1, which should tested at least 12 weeks apart. Antiphospholipid antibodies are pathogenic. It has been illustrated that antiphospholipids are associated with multiple mechanisms of action, including activation of cellular components, endothelial cells, platelets, and monocytes, activation of the coagulation cascade, inhibition of the fibrinolytic system, inhibition of natural anticoagulant pathways, and activation of the complement system. In this slide shows the central role of endothelial cells, monocytes, and platelets in induction of thrombosis in antiphospholipid syndrome. Immune cells, platelets, and endothelial cells activated by anti-beta-2 glycoprotein 1 antibodies. Complement is activated, which strongly accelerated the formation of thrombus. Activated platelets increase expression of glycoprotein 2B, 3E, and synthesis of thromboxane A2. In antiphospholipid syndrome-associated fetal loss, there is typically massive infarction and thrombosis of the placental and decidual vessels, probably secondary to spiral artery vasculopathy. Interference with annexin 5, a natural anticoagulant, might favor placental thrombosis and fetal loss. Also, antiphospholipid reduce HCG release and inhibit trophoblast invasiveness. Epidemiologically, antiphospholipid syndrome is a rare disease, and the prevalence of antiphospholipid antibodies and antiphospholipid syndrome in the general population is difficult to estimate due to the lack of population-based studies. A large review of the literature estimated that the prevalence of antiphospholipid antibody positivity is 6% among women with pregnancy complications, 10% among women patients with deep venous thrombosis, 11% among patients with myocardial infarction, and 70% among patients with juvenile stroke. Antiphospholipid syndrome is about 5 new cases per 100,000 individuals per year. The prevalence of catastrophic antiphospholipid syndrome, a rare life-threatening form of antiphospholipid syndrome, has been estimated to be less than 1% of all cases of antiphospholipid syndrome. And about 10 to 15% of women with a recurrent miscarriage are diagnosed with antiphospholipid syndrome. Antiphospholipid syndrome can be associated with a wide variety of clinical symptoms, from asymptomatic antiphospholipid positivity to a rare and life-threatening form called catastrophic antiphospholipid syndrome with microangiopathy. But the hallmark of the syndrome are thrombosis, either arterial or venous. Venous thrombosis are the most common manifestation between about 50%. Then arterial thromboembolism. However, obstetrical complications were found in about 10% of patients. Thrombosis are generally idiopathic or unprovoked, but traditional risk factors such as tobacco, inflammation, estrogen might have an important role at this point, and such risk factors are present in more than 50% of patients with antiphospholipid syndrome. Recurrences are frequent, and after a first episode, the risk of recurrence is about 10 to 67%, which justify a long-term anticoagulation in those patients. Obstetrical antiphospholipid syndrome can be associated with various pregnancy complications, of which recurrent miscarriage at less than 10 weeks of gestation is the most frequent. The material pregnancy morbidity of antiphospholipid consists of preeclampsia, eclampsia, and placental abruption. Several risk factors predict poor pregnancy outcome, such as an associated systemic autoimmune disease, in particular systemic lupus erythematosus, a history of previous thrombotic events, reduced complement levels, and lupus anticoagulant positivity or triple positivity. A prospective study of 10 pregnancies confirmed that Doppler ultrasonography in the second trimester is the best predictor for late pregnancy outcome in patients with antiphospholipid syndrome. The European League Against Rheumatism, ALAR, has now included recommendations on the use of uterine artery Doppler ultrasonography in their guidelines. In fact, between 22 and 24 weeks of pregnancy, the persistence of high resistance in the uterine arteries may reflect the failure of the uterine vasculature adaptation, thus being a risk factor for the consequent maternal and fetal pathologies. Many other clinical symptoms can be associated with antiphospholipid syndrome. A stroke is the most common and severe neurological manifestation. Also, epilepsy, valvulopathy, thrombocytopenia, or renal involvement with thrombotic microangiopathy. Livedo reticularis is a skin manifestation often associated with antiphospholipid syndrome. The laboratory detection of circulating antiphospholipid antibodies define the disease. And according to current laboratory criteria for antiphospholipid syndrome, antiphospholipid antibodies can be one of 3 types: lupus anticoagulant, anticardiolipin antibodies, or anti-beta-2 glycoprotein 1 antibodies, which should be present in moderate to high titer or on 2 occasions at least 12 weeks apart. Progress has been made on the standardization of tests as guidelines on lupus anticoagulant testing, and immunological assays for anticardiolipin and anti-beta-2 GP1 are published. The first criteria is lupus anticoagulant are defined as antibodies that prolong the phospholipid-dependent coagulation test by interfering with the coagulation reactions dependent on protein phospholipid complexes. The second criteria is anticardiolipin antibodies of immunoglobulin G or immunoglobulin M isotype in serum, present in medium or high titer and measured by a standardized ELISA. The third criteria is anti-beta-2 glycoprotein antibodies of immunoglobulin G or IM isotype, measured also by a standardized ELISA according to recommended procedures. Thus, the performance and choice of assays used for detection of antiphospholipid antibodies should be well considered and follow the guidelines. Recommendations by the Scientific and Standardization Subcommittee of the International Society of Thrombosis and Hemostasis are useful, and they were published to provide additional details and specification. Tests for all three antibodies must be performed to define a patient's full antibody profile. This concept includes the antiphospholipid type, the presence of multiple, double, or a triple versus single antiphospholipid type, their titer, moderate, high, titer versus low, and the persistence of antiphospholipid positivity. The antiphospholipid profile is an important factor determining the risk of thrombotic and obstetric events and consequently the intensity of treatment. A positive test for lupus anticoagulant is a stronger risk factor for thrombosis, and it's regarded as the most important risk factor for antiphospholipid-related thrombotic event. Then the presence of a double or a triple positivity of antiphospholipid and the presence of persistently high antiphospholipid titers. It was demonstrated that patients with triple positivity tend to have higher values of anti-beta-2 glycoprotein 1 compared with patients with less than 3 positive antibodies and are more likely to have stable concentration on antiphospholipid antibodies over the time. Testing for antiphospholipid antibodies should be limited to patients who have a considerable probability of having antiphospholipid syndrome. They are younger patients with unprovoked thrombotic events or thrombosis at unusual sites and pregnancy complication. Other antiphospholipid antibodies are not included in the criteria, but however, a strong association with thrombosis or fetal loss has been observed, like anti-prothrombin, anti-annexin 5, antibodies to vimontin or antiphosphatidylserine, or immunoglobulin A, anticardiolipin, and anti-beta-2 glycoprotein antibodies. Some scores have been proposed to stratify the risk of events in antiphospholipid syndrome patients. The first is the antiphospholipid score, has no clinical items and is based exclusively on the antibody titers. And the second score is the Global Antiphospholipid Syndrome score, the GAPS, which was developed in a cross-sectional study on patients with systemic lupus. The score includes traditional cardiovascular risk factors such as hypertension and hyperlipidemia and the presence or absence of antiphospholipid antibodies. The management of antiphospholipid syndrome remains a challenge, including primary and secondary prevention of thrombosis. Controlled studies showed the efficacy and the safety of long-term anticoagulation for thrombosis and the efficacy of aspirin and heparin for pregnancy morbidity. The recent EULAR recommendations provide guidance treatment in the adult with antiphospholipid syndrome. In asymptomatic antiphospholipid with a high-risk antiphospholipid profile, with or without traditional risk factors, prophylactic treatment with low-dose aspirin is recommended. After a first venous thrombosis, long-term treatment with vitamin K with INR target between 2 and 3 is recommended. Rivaroxaban should not be used with triple antiphospholipid positivity. Direct oral anticoagulation could be considered in patients not able to achieve a target INR with vitamin K. For arterial events, INR target between 2 and 3 or 3 and 4 is recommended. For obstetrical antiphospholipid syndrome, aspirin associated or not to heparin are recommended. With a history of thrombotic antiphospholipid syndrome, combination of low-dose aspirin and heparin during pregnancy is recommended. In a woman with criteria of obstetric antiphospholipid syndrome with recurrent pregnancy complications, increasing heparin dose or addition of hydroxychloroquine or low-dose prednisolone may be considered. Addition of hydroxychloroquine was also recommended by the new American College of Rheumatology guidelines for the management of reproductive health in rheumatic and musculoskeletal diseases. In conclusions, antiphospholipid syndrome is an heterogeneous syndrome. Many questions are still remaining about the pathophysiology. Thrombosis are different from a pregnancy morbidity. This syndrome is in evolution. What's new is the new recommendation of LAR for treatment, and many challenges remains. Thank you for your attention.
Yes, thank you, Dr. Fatin Frika. Thank you for your excellent presentation.
Thank you.
Yes.
It was pleasure for me to participate with you.
Yes, yes. And our next speaker is Dr. Subra Subramaniam from University of Minnesota, United States, and he's going to give a talk on anti-tumor immune regulation in colorectal cancer. And I request Dr. Subramaniam to start his presentation now.
Yep. Can you see my screen?
Yes, yes, yes.
Okay. Can you see the full screen now?
Yes, yes, yes. Please continue.
Okay. Thank you. Thank you for the invitation to be a speaker in this great conference. I'm just joining this meeting, so hopefully I can learn something from this communication. So my lab primarily focuses on regulation of anti-tumor immune response in colorectal cancer. Pretty much in the last 6 years or so, we have been focusing on how cancer evades immune response. To give some snapshots about colorectal cancer is the colorectal cancer is the second cause of cancer-related death in worldwide. I think in 2019, 1.8 million people were diagnosed with colorectal cancer worldwide. In the United States alone, more than 52,000 people died of this disease. One of the problems with this disease, what we recently found is, even there is an early onset of colorectal cancer. Patients who are less than 50 years of age, they have been diagnosed with very aggressive stage of colorectal cancer. That is concerning, and hopefully we can learn some more of the biology and mechanisms to kind of prevent colorectal cancers as an early onset. As you can see, this the data, 1 in 20 people will be diagnosed with colorectal cancer, and 60% of the colorectal cancer can be prevented by regular screening. So if we can identify polyps in early stages, they can be prevented from colorectal cancer. So when you look at the phenotype of colorectal cancer, there are two major subtypes. One is a microsatellite unstable group, and another one is a microsatellite stable group. These are the two major class of colorectal cancer. And microsatellite unstable types are like around 15% of the patient population. However, this microsatellite stable are 85% of the patient population. So the large number of patients belongs to this subtype, with microsatellite stable. So what do you mean by microsatellite unstable and stable? So in this condition, the DNA mismatch repair genes have mutations in them. So that means there is a deficient mismatch repair mechanism. So the mutation, whatever happens in the genome, is not corrected by these DNA repair genes because they themselves are mutated. So there is a large number of mutations accumulated in these tumors, and each mutation can somehow like develop into a like tumor antigen, and there's like a higher mutation burden converts to higher antigen load. So thereby the mutations have higher immunogenicity in nature. However, the large group of tumors where the 85% of the cases are microsatellite stable type, there is a proficient mismatch repair, meaning the DNA repair genes are not mutated. So thereby the mutations can be repaired. So if the mutations are repaired, there's a low immunogenicity in nature. So these are the two primary differences between these two subtypes. In the last, I would say like 60 years or so, we have like come so far in terms of the therapy development. But even so, 5-fluorouracil, which was discovered in 1962, is the primary standard of care for colorectal cancer. 5-FU is combined with various other chemotherapies like capecitabine or leucovorin or oxaliplatin with different names, Folfax or Folfuri. So these are combinations of chemotherapy. This is primarily given as a standard of care. Last 10 years has changed some differences in terms of understanding the tumor genes and then the genes that are oncogenic in nature. So anti-angiogenesis therapy, for example, targeting the VEGF gene is one of the targeted therapy that has been developed, and also the EGFR inhibitors. But the problems with EGFR inhibitors are more than 50% of colorectal cancer patients also have KRAS mutations. So thereby the EGFR inhibitors may not be the patients with the KRAS mutation may not respond to EGFR inhibitors. This is a major problem. When you look at the various treatment options, what we have in terms of the chemotherapy, targeted therapy, and the recently developed immunotherapy, so both chemo and targeted therapy, they work in the initial stages of the treatment, but eventually after like 1 or 2 years, they develop into resistance and the tumor grows normally like an untreated tumor. Whereas when you look at the immunotherapy treated patients, the tumor initially has lower response, but then they continue to respond, and then pretty much the tumor volume is pretty lower here for longer period of time. So the response is for longer period of time. If the patient responds in a longer period, there are several examples where the patients are cured of the disease. So eventually, when you have this combination chemo targeted and personalized in the right form, then there'll be a better survival rate in those patients. But this is what in the last 10 years we learned in terms of combination therapy. Talking specifically about immunotherapy aspects, the last 3 years are so like 2017, 18, and then so far, what we have achieved is like 3 major immune checkpoint blockade antibodies. One is anti-PD-1 and then anti-CTLA-4. So these are pembrolizumab and ipilimumab. These are the recent immune checkpoint blockade therapy, which has been introduced to combine with other anti-VEGF or anti-EGFR therapies that can be used in the patients. However, like I mentioned before, so even there are new therapies available, these therapies are not effectively being used in the colorectal cancer patients. For example, the immune checkpoint blockade therapy treated patients, when you look at the MSI patients who have the deficient mismatch repair, where there has a higher load of tumor burden, and thereby the immunogenicity is high, only those patients have higher progression-free survival, and the patient respond to those immune checkpoint blockade therapy. When you look at the MSS patient, they do not have the immunogenicity, so thereby there's a lower response to the therapy, and pretty much none of these patients are recovered. Same thing with the overall survival. There's a significant difference between MSI and MSS group of patients. So the key is 40% of the MSI patients have shown partial response to the treatment, and none of the MSS patients have shown any objective response to immune checkpoint blockade therapies. So the key is majority of the colon cancer patients are not candidate for current immune checkpoint blockade therapy. This is what we understood with all these clinical trials and so forth. So go ahead. Any questions? Okay. So the question is, how do you make colorectal cancer sensitive to immune checkpoint blockade therapy? This is what.
Hi. Okay. I'm at the meeting.
Okay.
Okay. Just call me when you're at the Foley. Okay. I'm coming in.
I think there is some kind of a crosstalk. So anyway.
Uh,
So making colorectal cancer sensitive to immune checkpoint blockade therapy is the key. But this is not that straightforward to answer because the tumor immune environment is so complex in terms of various factors playing a major role. For example, there are tumor cells in that environment, stromal cells and immune cells, and also colon cancer being like enriched with microbiota. There is also like contribution of the beneficial or oncogenic bacteria that can contribute to various aspects of immune response. So there's a complex environment in which these tumor cells and then immune cells function, and that is leading to various levels of immune response in the tumors. So what we're going to focus here is specifically looking at how colorectal cancer cells can interact with immune cells and then affect their immune response. So specifically looking at cancer and T cell interactions is what we are going to look at into further in terms of the immune response. When you're dealing with immune response in general, as you can see, it's also a very complex interaction of players. So first, the tumor has to release the tumor antigens, and then the antigen has to be presented in the right way by the dendritic cells, followed by the T cell priming in the tumor draining lymph node, and the trafficking of the T cells into the tumor environment, and recognition and killing of the cancer cells. So all these things has to be perfectly being kind of synchronized and organized in the tumor environment so that this effective immune response will take place. If any of these steps are having any issues, then there will be no immune response in those patients. So if you look at the immune scores of these patients, for example, these are normal tissues collected from the colorectal cancer individuals where these are normal colon, and these are the colon cancer tissues. These are tumor and normal comparison. You can see between the normal and tumor, normal has relatively higher immune score, meaning they have higher immune cell infiltrates into the tumor environment, and they also lead to kind of better survival in those patients. So patients with the higher immune cell infiltrates have better survival, with patients with the lower immune cell infiltrates have relatively low survival. So this is not a surprising thing, but we wanted to kind of establish how these immune cells are related to the patient survival. So when you specifically look at what immune cells are in the tumor environment, these are the various fractions of immune cells between the microsatellite high, low, as well as the normal colon tissues. And you can see this compared to the microsatellite stable group, all the rest of the other groups have higher levels of T cells compared to the microsatellite stable group. The microsatellite stable group has relatively lower levels of T cells. For example, here is an extreme case where you can see the microsatellite stable group has pretty much no T cells in that environment, stained by the red CD3 staining. And here with the microsatellite unstable group with higher levels of T cell infiltrates into the tumor microenvironment. So this is a stark difference between the MSI and MSS group in terms of the T cell infiltration. And when you kind of quantify the number of patients and look at this, most MSS patients have low T cell infiltration, and to a certain degree, some of the MSI patients also have low T cell infiltration. So T cell infiltration is a critical mechanism for inducing immune response. So there are multiple factors that affects T cell infiltration. So we know that T cells are limited in colorectal cancer, and for T cell proliferation, co-stimulation is a kind of critical or crucial factor that stimulates T cell proliferation. The co-stimulation is kind of is a signal that is induced by CD28 on the T cell surface, with interacting with the CD80 and 86 and the antigen presenting cells, specifically here in the dendritic cells. In the absence of CD28, for example, in this case, there's no CD28, the T cell undergoes apoptosis or anergy, and even in the reduced levels of CD28 or absence of CD28, there will be a kind of increased cell cycle arrest. So when the CD28 is not present, the cells will undergo cell cycle arrest and apoptosis, which leads to kind of depletion of T cells in that environment. So you need CD28 for normal proliferation, differentiation, and effector function in those in the tumor environment. And when we looked at specifically how CD28 is in the tumor environment, and we took this number of tissue sections from colorectal cancer patients, again, you can see CD28 is in green stain and CD3 is for like T cells overall. And you can see this is a case where there are T cells infiltrated into the tumor environment, and each T cells also have been like co-stained with CD28. You can see the staining here. But in this case, there are T cells, but the T cells are deprived of CD28 on their surface. They don't have CD28 pretty much expressed on their surface. Again, when you quantify the number of patients, what we kind of looked at the histology, majority of the MSS patients are either there's no CD28 or no T cells. So pretty much these patients have no immune infiltrates into the tumors without CD28. So what is the mechanism by which CD28 is regulated? CD28 is, as we know, it's downregulated in colorectal cancer. And here is the normal colon compared with MSI. And then these are the microsatellite stable group. So we took this TCGA, this is Cancer Genome Atlas database, which is having like nearly 500 colorectal cancer patients RNA sequencing data. And here you can see that majority of the colorectal cancer patients like MSS group do not have CD28 on their as a gene expression. And we also looked at corresponding like what are the microRNAs that can regulate CD28 and figured out with the complex algorithms and then understanding of how the microRNA works, we figured out microRNA 424 is a major player that can affect CD28 on the T cells. So here you can see there's an inverse correlation. When the microRNA is down, the CD28 is high in the normal and also in MSI. But in this case, we can see that microRNA 424 is generally higher in the cancer condition. So we wanted to further validate this, and you can see that by looking at the microRNA 424 levels, normal tissues generally have lower levels of microRNA 424, but whereas in cancer, including MSS and MSI group, you can see relatively very high levels of microRNA 424. And these are specifically expressed in the cancer cells, and here is a kind of a higher magnification. You can see the T cells with a higher level, cancer specifically, cancer cells have higher levels of the microRNA 424 with punctate staining. So when you compare the colorectal cancer to the normal tissue, these are matched tissues in terms of the patients. And you can see the cancer tissue have generally higher levels of microRNA 424. So the next question what we asked is how the level of microRNA 424 changes when the tumors are growing in an animal model. So we established a tumor model based on CT26 syngeneic tumor model. These are colorectal cancer cell lines. They are injected into the animal flank. And these animals will develop tumors within like 2 to 3 weeks, actually. These are very aggressively growing cancer cells. So you can see with the various stages of tumor growth, like 100 to 200 millimeter cube to 1000 millimeter cube, the tumor kind of grows much rapidly. So when you follow this tumor and then correspondingly look at their microRNA levels, like microRNA 424, in mouse, its ortholog is called 322. So basically 322 and 424 are same microRNAs. Pretty much the numbers are different between human and mouse. So you can see when the smaller tumor, then levels of microRNAs are relatively lower compared to the advanced stage disease or bigger tumors. And correspondingly, you can also see the T cell frequency also getting lowered in those models. And also CD4 and CD8 T cells, when you look at specifically those population, the CD28 levels are also getting lowered when the tumors are much bigger in size. So here is a heat map comparison in terms of the immune cell activation and infiltration. Again, you can see that in the tumor environment, when the tumors are smaller in size, there's an increased T cell activation and function, but when the tumors are bigger, pretty much they lost their immune response and activation. So this is our understanding in terms of what happens into the T cells when the tumors are much in progression. So first things first, we wanted to validate whether the microRNA 424 can bind to the 3' UTR of CD28 and regulates its activation. So we constructed a reporter assay, and the reporter assay showed that in the presence of microRNA 424, the reporter activity drops. So thereby it implies that the microRNA can bind to the 3' UTR and can regulate the gene expression. When you have a mutation in the 3' UTR, even in the presence of microRNA 4 to 4, there's no regulation. So this suggests that microRNA 4 to 4 can bind to the 3' UTR of CD28, and they can regulate their transcript levels. But the question here is, as we know, T cells has this CD28 on their surface. MicroRNAs are expressed in the cancer cells. So how they crosstalk and cross-communicate. So when you look at the literature, there's a significant number of papers showing that exosomes mediate intercellular communication. This is a well-established premise. So what we are kind of hypothesizing is cancer cell secreted exosomes carrying this microRNA can get into the target or recipient cells like T cells, and they can impart its function. So in the tumor environment, you can see the tumor secreted exosomes, which are red here, which carry the microRNA, can be drained into the tumor draining lymph node, where the T cells getting activated, they are primed and activated. They can also regulate that. When the activated T cells are getting into the tumor environment, again, the same exosomes with the microRNAs can also get into the T cells and then can affect their function. So the activation as well as the function of the T cells can be affected by the cancer secreted extracellular vesicles or exosomes. So this is a kind of hypothesis. So we wanted to validate that's the case. So we did in vitro co-culturing of T cells along with the cancer cell derived exosomes. And these exosomes are labeled with CD63 GFP. And again, you can see the Z stacking of the confocal imaging. And with the different layers, you can see the T cells in fact do uptake these exosomes, labeled exosomes. Not only T cells, also the dendritic cells also can effectively uptake these labeled exosomes. So this really establishes that both T cells as well as dendritic cells can effectively uptake the exosomes in the tumor environment. So again, this is an in vitro assay. So we wanted to validate in an in vivo model. So what we did is we took the same GFP labeled EVs and injected them in through the tail vein injection into these animals, and then these animals already have established tumors. And after 30 minutes, we took this tumor draining lymph node as well as spleen and looked at their T cells as well as dendritic cells. And specifically looking at the tumor draining lymph nodes and then the spleen of these animals, you can see the labeled T cells are present in both the tumor draining lymph node as well as in spleen. So also the dendritic cells from this tumor draining lymph node as well as spleen showed the positively are labeled exosomes. So meaning these labeled exosomes can get into the lymph nodes as well as spleen of these animals when we look for them to FACS analysis. Again, still this is an artificial system where we are injecting exogenously these exosomes. So we wanted to see whether tumor secreted EVs are themselves are taken by the T cells in the tumor environment. So here is an animal model with tumors, and these animals are injected with CT26, which can express GFP with the CD63, CD63 protein with GFP. So CD63 is a tetraspanin that takes on the exosomes, and whatever the exosomes which are coming out of these tumors will be labeled with GFP. So again, we are taking this spleen from the normal animal and the tumor from the normal animal and looking at the T cells in terms of the tissues, and found that the tumor infiltrating T cells which are having this GFP labeled ones are very high in the tumors. So this also implies that tumor secreted EVs are taken by the tumor infiltrating T cells in that environment. So with this, we can really speculate that there's enough amount of exosomes secreted in the tumors, and they are taken by the T cells in the tumor environment. So how about blocking this EV secretion in the tumors? So one of the key proteins for EV secretion is called RAB27. So this is a major molecule that is kind of supporting the EV biosynthesis. So when you block this gene, EV biosynthesis could be affected. And you can see the fold change of EV production by blocking this gene RAB27 by shRNA. And you can see this reduced levels of EV production when the gene is blocked. And when you take the same cell line and then inject into animal models and see whether they are growing in tumors, so you can see that cells with the blocked RAB27 has a reduced tumor volume over the period of time compared to the control cells. This also implies that blocking EVs could reduce tumor growth. But is it clinically possible to block EVs? And of course, the answer is no. We can't block EVs in a patient because EVs are needed or exosomes are needed for normal functioning of a human system. So you can't just generally block, and then even normal cells have the same mechanism of secreting EVs compared to the cancer cells. So you can't take this approach to reduce tumor growth. So what could be the other ways to kind of control tumor? Is that what we are trying to explore? So we wanted to see whether blocking microRNA 4 to 4 itself is a method that we can achieve by blocking tumor growth. So that's what we achieved here with the extensive animal in vitro data, in vivo data. And here we are injecting these animals with wild type CT26 cells. These are colorectal cancer cells injected into the flanks of these animals. And here is a MIRZIP control, meaning the control microRNA. There's no microRNAs in this vector. And here is the microRNA 4 to 4 MIRZIP. And here is a microRNA overexpression and CRISPR control and CRISPR knockout. So in all these cases, when you see the tumor development and growth, you can see with the MIRZIP 4 to 4 knockdown and in terms of knockout, there's a delayed tumor growth compared to the wild type and overexpression phenotype. So in overexpression as well, wild type phenotype, there's a significant growth of tumors in a short period of time. But in these two cases, there's a delayed tumor growth. And that also corresponds to a better survival in those animals. It's not exactly all the animals survive for a long period of time, but it is only an extension of survival of these animals when we block these microRNAs. And these are immune competent animals because these animals have T cells in their environment. But when we do this experiment in the SCID animals without any T cells, you can see the tumor pretty much has no difference in different conditions. So what we are seeing here is an immune response that delays the tumor growth. And when you look at the immune profiles of these tumors in terms of the T cell infiltration, again, it's a very low resolution in terms of the magnification. You can see more T cells with a red staining into the tumor microenvironment when you block the microRNA 4 to 4. Whereas in the controlled tumor as well as the MIRZIP control, you do not achieve the same levels of T cells in that environment. And also when you look at the other cell markers like CD45 for T cell activation and then other dendritic cell markers, you can see when we block the microRNA 4 to 4, there's an increased level of T cell infiltration and activation in that environment. Again, these are quantifications of various markers like CD28 and CD80 in that environment. So we also did another experiment to show whether this T cell infiltration is specifically antigen specific T cells that are infiltrating the tumors. So for that, we again took these exosomes. We injected into the animals. These are naive animals without any tumors and looked at the tumor draining lymph node and spleen tissues and tracked for T cells which are GP70 specific antigens. GP70 is a tumor antigen secreted by the cancer cells that what we are using. And when we take these exosomes, which are coming from the cancer cells, they also carry the GP70. So when you inject these exosomes in these animals, they trigger an immune response, which are specific to this GP70, which can be tracked by the tetramers that what we are using. So exosomes, which are injected without the microRNA 4 to 4 induce the highest level of GP70 specific T cell activation, and that is quantified here in this approach. Whereas the saline or wild type or microRNA control treated animals do not have higher levels of GP70. So this experiment shows that the T cells, specifically the antigen specific T cells, can be activated by the exosomes. So the key here is we want to increase the immune response in patients. And we know that exosomes carry the immune suppressive microRNAs, which can target CD28. At the same time, they also carry the tumor antigens like GP70. GP70 is one of the tumor antigens that we know of, but there could be so many other tumor antigens that can be exploited or investigated for further studies. So the idea is to block these immune suppressive factors and to provide these tumor antigens so that they can activate the immune response. So we did additional experiments where we have this naive animals injected with various EVs. So here is an experiment where we are using EVs as a vaccination. So we are treating these animals with 2 doses of EVs on day 1 and day 5 with like wild type or MIRZIP control or CRISPR control, or where the microRNA is blocked, or here is a CRISPR knockout EVs. with various EV treatments, you can see what happens is once you treat these EVs and then challenge these animals with tumor cells in the 14th day, and then follow this animal for another 14 days for the tumor development. So if we track this tumor growth in various treatments, you can see with only with microRNA 4/4 inhibited or blocked EVs, you can see a smaller tumor compared to the controls, and then also in wild type. In many cases, the tumor failed to develop without any establishment of tumors. So this is what we observed in many cases. And this is one of the smaller tumors. So blocking this microRNA and then providing this EV as a preconditioning stimulate the immune response so that when the actual tumor cells are injected, they prevented their growth in these model systems. However, when you take CD28 knockout animals or CD80 knockout mice, we do not see this response, meaning what we observed here is primarily because of CD28 and CD86 in terms of the tumor environment. Again, here's a quantification that clearly shows that when you block this microRNA in terms of knockout or knockdown, there's a significant reduction in terms of establishment of the tumors. So there are many unestablished tumors in that animals. So these are again models which are injected with flanks. As we know, colon cancer is not below the skin; it's in the colon. So we wanted to develop models where we can track tumors in the colon of these animals. What you're seeing is a mouse colon using mouse colonoscopy. So we have instruments where we can image the colon and also inject cells on the colon wall, basically by the endoscopy guided injection. So here is the colon wall injected with cancer cells. This is day 7. And within day 14 to day 21, you can see that tumor pretty much establishes as an primary tumor. When you look at the histology, which also resembles the human tumor in terms of the tumor growth. So this has been published in 2017 as a models for colorectal cancer. When you look at the immune response between the orthotropic tumors, where the tumors are developed in the colon wall, compared to the subcutaneous model we have been using to quickly understand the roles of microRNAs or exosomes, there's a significant difference in terms of the immune response. So what we have learned is there's increased T cells, B cells, as well as NK cells. And in the subcutaneous model, they also decrease. So knowing the exact immune infiltrates in these two tumor models are critical, because having the right model will be needed to develop the immune assays and also the exact dosing and then timing of the immunotherapy that we'll be developing in later stages. So knowing this, these two tumor locations have different immune response, we wanted to establish models which mimic high-grade tumors with metastasis. And we also spent like several actually years to kind of standardize this method where we can surgically implant tumor cells in the cecum of these animals. Cecum is a location where the small intestine and large intestine connects, which provides more space for the tumor to grow. So because that provides more space, it also takes the time to develop metastasis into liver. Again, you can see this in a primary tumor and also an established liver metastasis in this model. So using this model, we want to study whether our EVs with modified or blocked microRNA 4/4 will have an effect. So this is a model based on cecum tumors, and you can see a very high-grade tumor established with micrometastasis or metastasis to the liver. In the first week, these are all animals with established tumors treated with various combinations of EVs. Here's an IgG, which is a control, which ICBT means immune checkpoint blockade. That's with the PD-1, with wild type EVs with the PD-1, with microRNA control EVs with PD-1, and here is what we call it modified EVs or microRNA 4/4 inhibited EVs with PD-1. With various combinations, you can see only in the combinations of microRNA 4/4 with the PD-1 immune checkpoint blockade, the tumor is stabilized, meaning it is still growing, but it's not like in the other control groups where they're really much more progression compared to this group here. When you look at the corresponding levels of their survival in this animal groups, you can see where the IgG or ICBT groups here, they have pretty much lower survival rate compared to the group that is treated with blocked 4-4 and then combination of immune checkpoint blockade therapy. And also when you count the metastatic sites in these models, only with the combination therapy, we saw a lower number of metastatic sites into the liver. And this pretty established the premise that the combination of microRNA inhibited EVs with anti-PD-1 will increase the survival even in advanced stage disease models. When you take these tumor tissues and look for tumor T cell infiltration and then also activation of those T cells, again, the CD45 T cells, which are accounting for activated T cells, as well as granzyme function and Treg count ratios, all these measures shows that there's an increased immune activation or immune function in that environment. Again, these are the quantification, and see that with the compared to the other treatments, only by blocking this microRNAs in the EV with the PD-1 combination, there's an increased immune response. So this is what I think really encouraged us to kind of develop this into a further clinical trials. So currently we are kind of working with the human clinical trials office to develop into a therapy. So we have progressed from this preclinical models towards the clinical trial. So I'll summarize, I think because I'm running out of time, I'll summarize the data in terms of what we have learned and achieved so far. So during the normal stages of tumor growth in terms of early stages and late stage tumor, the T cell function pretty much drops in the late stage tumor, and then the immune checkpoint blockade efficacy also is generally known to be lower in the larger tumors. And we also observed that higher levels of microRNA 4-4 that leads to deficiency of CD28 and CD80, and higher levels of this microRNA along with this the tumor antigens in the T cells, because of the presence of the microRNA, they block the CD28 and co-stimulatory pathway that also blocks the anti-tumor immunity. And when you deplete this microRNA 4-4 and take this modified EVs only with the tumor antigens, and they can specifically activate the T cell response and can achieve the anti-tumor immunity when you combine with the immune checkpoint blockade. So in a tumor model with metastasis, combination therapy had a tumor control. Only with immune checkpoint like PD-1 did not have any tumor control, they had a tumor progression. So this is what we observed so far in terms of our mechanistic aspects of T cell regulation, specifically looking at T cell co-stimulation as well as the tumor control using these preclinical studies. We also did studies where we specifically removed the tumor draining lymph nodes, because when patient undergoes surgery, most patients with micrometastasis or metastasis will be recommended to remove the tumor draining lymph nodes. So we did studies in comparison of with and without the tumor draining lymph nodes, and then found that when tumors are smaller, you need the presence of tumor draining lymph nodes to control the tumor. But however the tumors are established in a secondary stage, the presence or absence of tumor draining lymph node did not have any effects on their outcomes in terms of the tumor growth. However, when you have the chemotherapy combined with immunotherapy as a concurrent therapy or a sequential therapy, what we observed is sequential therapy is better than concurrent therapy for controlling the tumor growth. So with this is also published recently in iScience, so you can look at the paper. So the idea here is the tumor treatment timing as well as the presence and absence of lymph nodes has so much of influence on the immunotherapy. So a lot of quantification in terms of mass cytometry data. And again, to show that when you have the sequential therapy, combination of 5FU with anti-4-1BB, this is immune checkpoint blockade, there's a higher T cell frequency and other immune cell markers. So all these things are good, but we have just scratched the surface of the iceberg. So many things are happening in the tumor environment in terms of the microbiome, exosomes, immune cells, and then metabolic fractions within the tumor environment. So the crosstalk between all these different players are very critical to understand how these can be combined in terms of the better prognosis and better survival in these patients with the treatments. With that, I'll thank my lab members who have extensively worked on this project, primarily Lihua Lee and Shenda. Both are MD PhDs and other graduate students and then postdocs in the lab. And I'll thank also my funding who supported most of our work based on the what I presented just last 30 minutes. I'll stop here and take any questions. Thanks.
Yes, thank you so much, Dr. Subramanian. That was an excellent presentation. And we are open for questions. If anybody has question, please ask.
Yes, Dr. Subramaniam, this was a very interesting talk. I'm Shopna Chaudhary, and I have worked on glioma immunotherapy all through. So I was interested to know that since there's the microbiota present in the colon, does it stimulate non-specific immunotherapy, which is conducive to glioma killing? And
Yes.
I have another question that in CD28 depleted T cells, was CTLA4 upregulated?
Okay,
And-
so
And
the
I
first
have another question, may I ask totally? And the other question was that you have created very beautiful models of colon cancer. And we have also seen that the metastasis going on. So do you think your immunotherapy or deprivation of the immunotherapy does some way stimulate the angiogenic cascades for the metastasis to, be stimulated?
Okay, so yeah, thanks for this question. These are wonderful questions. The first question, pretty much whether the microbiota has an influence on the immune response and then immune outcomes, that has been established very clearly. So there are specific bacteria that metabolic fractions what are secreted can really support the tumor environment or block the tumor in terms of the immune cells. So when you look at the tumor environment, the metabolic requirements of the cancer cells are different compared to the T cells. So if the bacteria is not providing the right metabolic fractions that are supporting the T cell environment and T cell growth or proliferation, that means even in the presence of all the right environment, the T cells won't proliferate. So that's a role of this microbiota that can support the immune cell infiltration and proliferation. So that's been established. And on top of it, when you give the immune checkpoint blockade therapy, the immune checkpoint blockade therapy is only a sustenance of the T cell response. It's not going to stimulate the immune response. It's only the sustaining the immune response, what is already there. Because that's a right, there's no right combination of the metabolic fraction and also the suppression from the tumor itself, the tumor intrinsic factors, these T cells will not be having a right environment to proliferate. So that's one of the reasons why these microbiota can affect the immune cells as well as the immune checkpoint therapy in terms of their function. The second question is whether CTLA4 is found on these T cells when there's absence of CD28. Of course, that's the primary mechanism by which T cell energy is induced. When there's a decrease, whenever there is an activation of T cells, it's a counterbalance of how the T cell really functions to avoid autoimmunity, because the higher levels of CD28 and sustained expression of CD28 can also induce autoimmune response. So evolutionarily, T cells have developed its own control mechanisms where when CD28 goes up, it also simultaneously increases CTLA4. So that's why we come with the ipilimumab or CTLA4 antibodies to block CTLA4 to sustain the CD28 levels. So obviously what we have tested is in colorectal cancer specifically, CTLA4, PD1, PDL1, they are not expressed because CD28 is not increased and thereby there's no countermeasure for these two to go up. Right. So naturally, there is a decreased level of co-stimulation and also decreased levels of this immune checkpoint genes in that environment. So that's already been established by our group and other groups. And the last question is whether there's an angiogenic factors that can kind of affect this thing. I don't know. We have not specifically looked at these aspects, but I would assume that tumor has certain levels of angiogenesis, and that is why there is a VEGF inhibitors which can be increasing the survival in patients, which already been established. So now finding the right timing of VEGF inhibitors along with immune checkpoint and maybe to induce the immune response with modified EVs, these are the combination that has to be tested in further future models. Hopefully this answers your questions.
Yes, thank you. But don't you think that inhibiting VEGF only leaves other pathways like EGFR, PDGF, which goes through the same pathways of proliferation of the angiogenic vessels. So, to me, blocking only one agent, VEGF, VEGFR, doesn't block other pathways. Don't you think so?
True. This is an established premise in cancer therapy now. Single agent therapy or single treatment is not going to be effective, and it may be effective for a very short period of time, but over a period of time there will be other counter mechanisms on counter pathway which will always be there. So combination therapy is the key, and that's one of the reasons why we still use the combination with 5-fluorouracil and then combining with the targeted therapy. Now that we also know that immunotherapy can also improve outcomes, but right now immunotherapy is not working in colorectal cancer patients. So the key is to how to bring immunotherapy to colorectal cancer patients in combination with the targeted therapy and maybe chemotherapy. So that's why in the last data I showed you the timing of the treatment, whether it's a concurrent treatment or sequential treatment, how that's going to affect the outcomes. So everything has to be really worked out in terms of the timing, dosing, and the patient conditions. So a lot of things has to be done.
Thank you so much.
Thank you so much, Dr. Subramanian.
Yeah, thanks.
Our next speaker is Dr. Charles Malemud from Case Western Reserve University, United States. And I request Dr. Malemud to start his presentation now.
Hey, thank you very much for being so patient with me. I have actually the senior author of this PowerPoint here with me, and so I'm ready to begin.
This is the PowerPoint we used
Yes.
last time. Okay.
By way of introduction, some of my laboratory group studies rheumatoid arthritis related mechanisms. And we are interested in understanding the underlying mechanism for how certain of the FDA approved drugs work. Thank you.
Sorry.
I don't get it. I just don't understand. I'm sorry, we're having a little bit of a problem here, but we'll be there soon, I hope.
No problem. Please take your time, no problem.
There are many drugs now available for the treatment of rheumatoid arthritis. As distinct from the fact that there is essentially no approved drugs for osteoarthritis. A recent clinical trial with an NGF antibody showed it to not be successful in limiting the amount of time between the diagnosis of osteoarthritis and total joint replacement. So it's 2021. We've been working on this for many, many, many years, several decades. And we're trying to figure out how to apply some of the things we've learned to, thank you. This one. Okay. So what I'm going to do today is tell you about some recent experiments we've done with one of the drugs that's approved for the treatment of rheumatoid arthritis. And the mechanism as to how it works has been published in terms of its effect on the so-called JAK-STAT pathway. My lab decided to look at how the use of tofacitinib, the commercial name is Xeljanz, how does it work on cartilage? Cartilage has been a major target for osteoarthritis studies, but in rheumatoid arthritis studies, the major target has been synovium or macrophages. Okay,
Do you want me to come back?
I think it'll be okay. Thank you. So we're going to look at the effect of tofacitinib on Janus kinase activity. And we hypothesized that Janus kinase was an important component in the expression of matrix metalloproteinase genes, which are instrumental in destroying cartilage over the course of treatment, even with rheumatoid arthritis treatment, mainly looking at other markers of disease processes. So I just need to get through a few what we call issues dealing with conflict of interest, et cetera. These are the study collaborators on the project. Sam Messiano is my colleague in reproductive biology here at Case Western Reserve University. The reason we got involved with Sam is because mechanisms that seem to initiate preterm birth are also relevant in inflammatory episodes that affect rheumatoid arthritis patients. So we decided to combine our laboratories, and we are working on several very large NIH-supported projects dealing with preterm birth. Jessica Thorpe, who was actually sitting next to me a few minutes ago, is a master's degree student, and she completed her degree with me, as did Rachel Wilson, and two summer students, Mihar Panchel and Nathan Liu, were involved. And here's the disclosures. So we had a contract between CWRU and Pfizer. Pfizer is the manufacturer of tofacitinib, as well as an R01 from the NICHD here in the US. Dr. Messiano is the PI, and I am co-investigator. And CJM and JT, that's Jessica, we received salary support from the Pfizer contract, and the tofacitinib committee at Pfizer approved the study design, but had no role in its implementation. And I also received salary support from the R01. The authors, all of us, declared no conflict of interest, and I have complied with requirements established by CWRU to inform the university of any potential conflicts of interest. Okay, so one of my students, now almost 13 years ago, 14 years ago, we studied similarities and differences between rheumatoid arthritis and osteoarthritis. And we noted that in terms of cytokines, there was a significant overlap between the cytokines produced in RA and OA, the most prominent of which are TNF alpha, interleukin 1, and interleukin 6. And the expression of these cytokines, which can be amplified, by the way, through the JAK-STAT pathway, led to a significant increase in the level of matrix metalloproteinases, MMPs, and the loss of extracellular matrix proteins through an inhibition of synthesis by these cytokines. And moreover, in OA, these cytokines produce an effect on apoptosis, so that chondrocytes in the OA scenario are killed by apoptosis, and there's no stem cell in cartilage that we know of to replace those cells that are lost. Consequently, if you look at an advanced case of osteoarthritis, the cartilage looks essentially devoid of chondrocytes. The opposite is true in RA, where the T cells and other associated immune and non-immune cells appear to become immortalized. And there's a significant level of apoptosis resistance. My lab has published several studies on that. What about the MMPs? Well, matrix metalloproteinases are produced as proenzymes. They need to be activated. And there's an endogenous inhibitor family called tissue inhibitor of metalloproteinases, but in the arthritic setting appear to be deficient in both the amount as well as their activity. So after activation, the MMPs just go to town, so to speak, on the cartilage and associated tissues within the synovial joint. And the ones that are most prominent are MMP1, which is a collagenase, MMP2, which is a gelatinase, MMP3, stromolysin, MMP9, which is another gelatinase, and one called MMP10, which is responsible for activating the zymogen form of MMPs. In OA, MMP13 is a prominent, and not much study has been done on MMP13 in the RA setting. Notice too that the, okay, let me go on. So we wanted to look at, since tofacitinib has been reported and published to be a JAK inhibitor, we became quite interested in the JAK-STAT pathway. And here you can see, using IL-6 as an example, that IL-6 combines with a cytokine receptor called IL-6R alpha and leads to the phosphorylation of JAK, Janus kinase. That phosphorylation step responds intracellularly in the cytoplasm by recruiting STAT proteins. And these are phosphorylated so that it's hypothesized that inhibition of JAK would reduce the number or the amount of phosphorylated STAT, because when phosphorylated STATs are produced, they form dimers, either homo or heterodimers. And these STAT dimers act as very potent inhibitors, very potent transcription factors. And so we wind up with a number of gene expressional events, which are quite important in maintaining the inflammatory response typical of both RA and OA. Now, a number of other negative regulators generally sidetrack this pathway when it's activated. But we just published a paper a year or two ago which showed that the JAK negative regulators are deficient. And so we hypothesize that in the absence of negative regulation, a constant presence of TNF alpha, IL-1, and IL-6 would stimulate the production of MMPs. And we focused on IL-6 because it's a potent regulator of JAK-STAT pathway. Now, the structure of JAKs are important because we wind up knowing how the JAKs are inhibited by looking at the various components of the JAK-STAT component. That's the JAK structure is shown here. The original hypothesis was that it would combine with the JH2 pseudokinase domain, but later on, additional studies showed that it was the JAK inhibitors bind to JH1. Some JH2, SH2, and very little to the firm. So this is the canonical IL-6 signaling pathway that we've been focused on. And what you can see here is IL-6 combines with its receptor on the membrane. And along comes another protein called GP130, which is actually the signal transducer, leads to autophosphorylation of JAK, in this case, JAK3, and that leads to the phosphorylation of STAT3, and STAT3 is what winds up to form homodimers, and you wind up with an on signal. The on signal is balanced by an off signal under normal conditions. A family of proteins called SOCS for suppressor of cytokine signaling, as well as SH1, which is a phosphatase, which uncouples the activation step. So this is basically the pathway we looked at. Now, there's another pathway which is very prominent in RA, and that's the one that's through the soluble IL-6 receptor. It's called the trans-signaling pathway, and how this is produced is through an enzyme family called ADAM, and the homologue of this pathway in OA is ADAM with a thrombospondin motif. And it's interesting because in the absence of any inhibitors, this pathway is very active. And we found that tofacitinib can combine with both the soluble receptor as well as the membrane-bound receptor, although in this trans-signaling pathway, GP130 is not required. And just to bring all of this kind of together, these are the relevant signaling pathways in RA synovial tissue. And you can see that the prominent one in the center of the diagram of the cartoon is TNF alpha. And we all know that there are significant numbers of TNF alpha inhibitors that are approved for use in RA. They include adalimumab, etanercept, infliximab, and they are very prominent in the treatment of RA. And we all know that these are very good inhibitors, but over the long course of treatment of RA, patients become resistant. There are other pathways that affect the synovial fibroblast, and shown here. One is called the FAST pathway. That's the apoptosis pathway. And of course, the IL-1 pathway is not shown here. But downstream, we know that there's an effect on the genes that control MMP production. And that's the AP1 transcription factor binding region. So we didn't get to that part of the study. Contract called for us to determine whether tofacitinib inhibited matrix metalloproteinase gene expression in the presence of IL-6. So that's what we'll focus on now. But before we do, I just wanted to go over this. What do we mean by the destruction of articular cartilage? I mean, why do we worry about that? Well, this is a model of the structure of aggrecan, which is the sulfated proteoglycan. That really is the biomechanical mechanism for the resistance of articular cartilage to compressive forces. It does so by binding water, and significant amounts of chondroitin sulfate-rich components are the water binding area because these are sulfated and have polyanionic charge. So in order for cartilage to resist compressive forces, this molecule must remain intact. But when matrix metalloproteinases are activated, this is what happens. On the left side, you can see the intact proteoglycan. I won't get into the various regions. But as the matrix metalloproteinases act on the cartilage, it cleaves the components of aggrecan, which are important for its normal homeostatic function. Until at the end of the process, all we see using electron microscopy is this hyaluronic acid binding region called G1 bound to hyaluronan. And what happens is, mechanically, the cartilage loses its function. So maintaining the structure of aggrecan is quite important. Now, keep in mind, I said earlier that another effect of IL-1 and other cytokines, pro-inflammatory cytokines, is to inhibit the synthesis of aggrecan and other ECM proteins. So there's a double effect. One is the destruction of already existing aggrecan and the inhibition of aggrecan synthesis. Oh, sorry. Okay, so let's get into the study we performed. We used normal human chondrocytes. These were obtained from a commercial source, and the C28I2 line of human juvenile chondrocytes, which were immortalized and were given to us by Mary Goldring, who's a professor at Cornell, the Hospital for Special Surgery in New York City. And what we did is we measured the response of the immortalized chondrocytes to recombinant human IL-6, and we did an assessment of three STAT proteins, 1, 3, and 5. And we looked at the effect of tofacitinib and another small molecule inhibitor, ruxolitinib, on IL-6 induced STAT activation, and we measured this by quantitative Western blot analysis. And the experimental design was originally to compare a pre-incubation of the normal human chondrocytes with tofacitinib or ruxolitinib, and also the concomitant incubation with IL-6 and tofacitinib or ruxolitinib. But most of the studies I will talk to you about today were pre-incubation studies. Okay, we did a lot of statistics because we found that it was quite important to be able to quantify what was going on. And we used a whole host of different statistical measures that were decided upon before the study began. And you'll see those marked on the various slides coming up. I'm not going to show you the effect, the normal chondrocyte, because most of this talk is on the C28 cells, but we did look at normal chondrocytes, and I can tell you that the responses we saw with normal chondrocytes overlapped with this immortalized cell line, so we consider C28 to be a useful surrogate of normal human chondrocytes. Okay, well, here's the effect of IL-6 on STAT content measured. We call that USTAT3 because it's unphosphorylated. And this is the experiment. We compared no additions with IL-6, and this is the Western blot. You can see that there's basically no effect of IL-6 on the already existing USTAT3. But when we looked at the activation of STAT3, we found a significant increase in the phosphorylation of STAT3 compared to no additions. So when we completed this experiment, we knew we had a system that was working as we predicted, which was that IL-6 would activate STAT3, and this would lead to downstream effects. And again, the one we studied was the effect on MMP gene expression. And I'm going to show you one or two slides on looking at MMP synthesis or production as well. What about STAT1? So STAT1, the same effect. Essentially, when IL-6 was added and we looked at USTAT1 using the USTAT1 specific antibody, this Western blot showed, as we found with STAT3, that there was no effect on content. However, when we did experiments with pSTAT1 to look at pSTAT1, we found, again, a stimulation of phosphorylation of STAT1. So the two relevant stats that we were going to look at, STAT1 and STAT3, they seem to be affected by IL-6 in the model that we had figured out before we did these experiments. We also did studies on STAT5, but here's the results quantified. And we use GAP-DH as the baseline. So the USTAT3 to GAP-DH ratio was 1.2. pSTAT3 to GAP-DH in the presence of IL-6 was 91.2 times. And USTAT1 to GAP-DH, a small increase. So you can see that the quantification that we use, the ImageJ software, was able to pick up a small increase in USTAT1 in the presence of IL-6, but this was not statistically significant. PSTAT1 to GAPDH almost 14 times, and the PSTAT3 to the USTAT3 was 52.3 times, and the PSTAT1 to USTAT1 was 10.4 times. So we have a useful model using the C28 cell line. And so the results imply and support the previous studies that we did with other cell types, as well as those published by other investigators, that IL-6 activates PSTAT3 without altering the content of STAT3, and IL-6 also increased the content of USTAT1, but not as much. Now we're going to be going on and looking at this in more detail because a colleague of mine down the street from where I am at the Cleveland Clinic, George Stark, and his research team have shown that the unphosphorylated stats can also act as transcription factors. But we haven't looked at that yet, but that's one of the plans we have to determine whether the unphosphorylated stats also act as transcription factors. And again, we're not saying that we have done that, but we are going to look at that. I think that's an important. And we published several reviews on the subject, starting with a review that we published now 12 years ago, and a paper that I published a decade ago, effect on pro-inflammatory cytokines, which really served the basis for a lot of what we did over the last 3 years. Okay, now, what about tofacitinib? Okay, so we looked at the effect of tofacitinib on PSTAT1 using the pre-incubation protocol. That is to say that the cells were incubated with IL-6, with tofacitinib for 30 minutes, and then incubated with IL-6 and tofacitinib for additional 30 minutes. And here are the results. Again, we see quantified that the IL-6 at 20 nanograms per mil increased the phosphorylation of PSTAT1, and tofacitinib at very low concentrations from 2.5 to 20 nanomolar, and is upwards of 50 nanomolar, inhibited the phosphorylation. But when we went to 100 nanomolar, and in most of these experiments, we saw not really a significant effect. It was borderline, but was not significant. Oh, now, what about USTAT1? So this was the real surprise. It had not been reported that tofacitinib inhibited the content of STAT1. But here we have an experiment which shows that concentrations of tofacitinib in the presence of IL-6 from 20 nanomolar to 100 nanomolar inhibited the content of USTAT1. So this was very startling to us because it represents a new finding and has repercussions in terms of the stat content. And what's interesting is, and this is why, because I've been interested in chondrocytes over the last almost 50 years, why we think studying cartilage and chondrocytes is so germane to understanding the effect of these drugs in rheumatoid arthritis, because our background did not suggest that tofacitinib would be an inhibitory molecule towards the unphosphorylated stats. So this was really an unexpected finding. I'm sorry, having just a little problem here. Okay. Now notice that when we did a concomitant incubation, that is when we added tofacitinib and IL-6 at the same time for 60 minutes. No effect. Even though we could confirm the IL-6 effect being statistically significantly increased, proof that STAT1 had been activated. No effect when the concomitant incubation was performed. And I'll get to the implications of that finding towards the end of my talk. Same thing on USTAT1. And here's some other data. And the reason why we looked at ruxolitinib, and this was work we were doing, in, as I said, in collaboration with Dr. Messiano on the preterm study, was because tofacitinib is now well known to be a pan-JAK inhibitor. It inhibits JAK1, JAK2, and JAK3, although to varying amounts. The IC50 for these have been published. Very influential paper by Yamaoka showed that it is not a selective inhibitor, but rather a pan-JAK inhibitor. But ruxolitinib is a JAK1, JAK2 inhibitor. So we wanted to see whether if ruxo performed in the same way. And what you can see, I want you to focus on the bottom two. The bottom one is GAPDH, and the next one up is the p-STAT1, p-STAT3. And you'll notice that there is an inhibition of ruxo. So it looks like even though JAK3 remains uninhibited, this effect really looks to be a JAK1, JAK2 phenomenon. Okay. Okay. I don't know what happened here. Okay, this is the pre-incubation study. Notice the effect of ruxo at 100 nanomolar and 50 nanomolar, 20 nanomolar. There's a reduced intensity of the bands. Another one, just confirming the same results. So this is just this is the concomitant incubation. Now, interestingly enough, at high concentrations, it looked to be as if ruxo was a better inhibitor in the concomitant incubation than was tofacitinib. And again, I'll get to the implications of that at the end. Now, I'll just show you a bit on IL-6. The IL-6 effect is shown on the left. This is taken from a paper published, about 9 years ago. A very nice cartoon. IL-6, JAK1, JAK2. But we now know that JAK3 is also inhibited. So the results of those experiments came out. However, notice that the fourth member of the JAK pathway, TYK2, can also be activated by IL-6. Well, we didn't have an inhibitor to test for that. And shown here are a number of other pro-inflammatory cytokines, as well as erythropoietin, which also can activate the JAK-STAT pathway. Now, what about the MMPs? So we used the quantitative PCR method to look at this. And what we did was, first of all, we wanted to know, does the C28I2 cell line, the chondrocyte cell line, do they produce the MMP types found in human cartilage? Otherwise, the model system becomes not as useful. And we noticed that the way to go about this was to first look at IL-1, because we have a lot of data on the MAPK pathway, which is activated by IL-1. First, notice that the IL-1 does in fact increase several of these MMPs, but not all of them. MMP3 and MMP13 are the most activated, and MMP9 just about is activated, but it didn't quite reach statistical significance at the 0.05 level. We could find no evidence for a statistically significant increase in MMP1 or MMP2, although the amount was trending towards the significance. We then used 3 small molecule inhibitors of 3 kinases that are known to be important in MMP production, ERK, P38, and J&K. And the most visible inhibition was with MMP3 and MMP13. And notice that there's a statistically significant effect of all 3 inhibitors. So this basically confirming what we had published many years ago, as well as others, that IL-1, an activator of the MAP kinase pathway, is important in the production of MMPs. And I'll get to this, the significance of that. Again, I'll also comment on that at the end. Now, what about IL-6 and tofacitinib? Well, you'll notice that we have an inhibition of MMP3, and MMP13 by 10 nanomolar in the presence of IL-6, a somewhat of a reduction in MMP9, but virtually no effect on MMP2 and MMP1. So we now know that the same concentrations that affect activation of STAT1 and STAT3 also results in an inhibition of MMP3, MMP13, and we think MMP9, it's borderline statistically significant. Oh, God. So we then, just recently, in fact, looked at synthesis, and we used immunohistochemical analysis. And what we showed here is that these are the pictorials, and oh gosh, okay. Well, what it showed basically was that the borderline effect on gene expression of MMP9 was actually probably an important finding, because we quantified those immunohistochemical cell responses and proved to be significant. So we now know that MMP9, MMP3, and MMP13 are reduced by tofacitinib. And so here's a kind of a summary of those findings. And what I wanted to say on the precondition, on the pre-incubation conditions, and why we think that that's an effect that's important. So there are 3 things going on in the treatment of chronic rheumatoid arthritis. One is that we now have drugs that specifically target components of the RA process that we know are involved in the progression of the disease. What we don't have is any understanding yet of whether or not, if we combine drugs, what would happen. So the standard of care for rheumatoid arthritis is you can't use more than 1 biologic. But what if you use a biologic, TNF alpha, let's say inhibitor, and the tofacitinib small molecule inhibitor? That wouldn't violate the standard of care. Those studies have not been done. Well, what some of our in vitro studies suggest, most of our, is that using one or the other simply won't cut it when it comes to inhibiting the total synovial joint effect that RA has. And we're not even looking at the immunological study. We're just looking at target tissues such as cartilage, synovium, bone, etc. We don't know how tofacitinib affects other cells involved in the immune process, at least in using some of the techniques that we've exploited in this study. Okay, now, the last piece of data I'm going to show is that we showed, looking at the compartmentation of pStat3 and pStat3, that basically at the end of 60 minutes, there's a significantly greater amount of pStat3 in the nuclear fraction, and that's significantly reduced by IL-6 plus tofacitinib at the 50 nanomolar concentration. But what we didn't expect was that tofacitinib also reduced the amount of total STAT3, the so-called unphosphorylated STAT3. And this occurred at 30 minutes and was sustained at 60 minutes. So here we have a situation, at least using these cells, that tofacitinib has a significant effect on reducing the amount of activated STAT3 in the nucleus, where it would work as a transcription factor, a result we did anticipate, but we did not anticipate that it would have an effect on USTAT3, which, as I said, my colleague George Stark has previously shown can also act as a transcription factor. So down the road, we have to look at that and see what effects the unphosphorylated STAT3 have on gene expression. We have a number of gene expression candidates. But also notice that there's no effect of tofacitinib except at 60 minutes on pSTAT3 in the cytoplasm. And that probably represents what's left over. So we're looking into this, and this may be an area that we're also going to track down. Okay, so this is just a summary slide. We know that there are several JAK inhibitors, JAK inhibs in various stages in development for RA. Several of these JAK inhibs inhibit different JAKs. For example, baricitinib is very similar to Ruxo. Dasatinib is selective for JAK3, and filgotinib is selective for JAK1. And in these studies, both tofacitinib, pan-JAK, and Ruxo, JAK1, JAK2 selective, were shown to be effective inhibitors of pSTAT protein activation. Now, it's important to note that when we say selective, it simply means that in cell-free protein kinase assays, the IC50 for JAK1 and JAK2 was discriminated from the effect on JAK3, and that's in the ruxolitinib. Right now, a few of these, including filgotinib, are undergoing clinical trials, and maybe another JAK1 inhibitor approved for RA. Okay, come on. Okay, I think we're done. I'll stop this. I'm here to answer any questions. Like, what happened to my, I'm having trouble here, folks.
We can hear you. We can hear. Thank you so much, Dr. Malemud. It was an excellent presentation. Thank you so much. And we are open to questions now. If anybody has questions, please ask Dr. Malemud.
is that at a specific time during the OA process, the synovial joint components of OA and RA overlap. So here's what we call the crux of the problem. We have a lot of very well and reproducible animal models of RA. The OA story is a little bit more difficult to interpret. We were involved in rabbit studies, we've done mouse studies, we've done all sorts of studies. But the recapitulation of what we think is going on in OA in the small animals wasn't exactly reproducible from animal to animal. When we went to big animals like dogs and horses, that was another issue. The dog studies were very reproducible, but nobody wants to do the dog studies anymore. They're very expensive. And so we're really left with a very difficult problem, which is the animal model issue. And somewhere down the line, we may be able to overcome it, but until we do, it'll be very difficult to assert to the FDA those molecules which we think may be important. Okay, thank you very much, ladies and gentlemen. I wish you good luck on the rest of your meeting.
Thank you so much, Dr. Malemud.
Thank you.
Yes, thank you. Our next speaker is Dr. Jinghong Wang from University of Colorado, Anscoot Medical Campus, United States. And I request Dr. Jing Wang to start her presentation. Please.
Can you hear me now?
Yes, we can.
Thanks for inviting me. By the way, I'm not at University of Colorado anymore. I just moved to University of Pittsburgh. So the title of my talk is MHC class 1 independent activation of virtual memory CD8 T cells induced by chemotherapeutic agent treated cancer cells. So first, I will give you a little bit of background. So major histocompatibility complex or MHC class 1 molecule are expressed on every nucleated cells in our body. And cancer cells can evade immune recognition by losing MHC class 1. And therefore, MHC class 1 negative cancers represent the most challenging cancer to be treated. So I'm sure some of you probably know this, just to make sure everybody is on the same page. So this is antigen presenting cells or APC. So they express MHC class 1 or MHC class 2, major histocompatibility molecule. And they present peptides or antigens to the T cells. And T cell recognize it with T cell receptor. And the T cell also express CD8 or CD4. These are called T cell surface glycoprotein. They will bind to the MHC class 1 or MHC class 2 to stabilize this interaction. So as you can see, T cell receptor always recognize the antigen in the context of MHC. So if the tumor cells express MHC class 1, it can be recognized by the CD8 T cells. If it express MHC class 2, it can be recognized by the CD4 T cells. However, tumor cells can downregulate MHC. So now you can see they don't express class 1 or class 2. They cannot be recognized by CD8 or CD4 T cells in an antigen-specific way. And the MHC downregulation is a common way for tumors to achieve immune evasion. And more than 60% of human B-cell lymphoma show reduced MHC class 1 and class 2 expression. And the deletion of class 1, class 2, especially class 1, also happen to other type of cells. And this is just an example of a paper showing, so MHC class 1 has two chains. One is alpha, one is beta. So the beta-2 microglobulin mutation happened very frequently in diffuse large B-cell lymphoma. This is another paper summarizing all the hard and soft lesions affecting the MHC class 1 locus in the cancer cells. So apart from the MHC class 1 deletion in the cancer cells, the MHC deletion can also be associated with immunotherapy resistance. So this is an example of a paper showing mutations associated with this particular beta-2 microglobulin gene can somehow show the resistance to PD-1 blockade in melanoma. And just a little bit of background on virtual memory CD8 T cells. So they are a new subset of CD8 memory T cells, and they show innate-like properties and produce interferon gamma upon inflammatory cytokine stimulation in an antigen-independent manner. And the VM CD8 T cells acquire their memory phenotype in response to IL-15. And also this VM CD8 T cells express a high level of chemokine receptors like CXCR3 and also adhesion molecules. This will allow them to be efficiently recruited to peripheral tissues and that release damage signals. And there are not that many studies about VM CD8 T cells in human cancers, and there are some paper, maybe just 2 of them, showing the innate-like memory CD8 T cell activation correlates to the remission of chronic myeloid leukemia or CML. And these are just some papers about VM CD8 T cells in case you're interested in them. This is a very excellent review, Nature Review Immunology, talking about the VM CD8 T cells. So the question we have at the initially, so everybody knows the chemotherapeutic drugs not only directly cure cancers, but also modulate the tumor immune microenvironment. However, it remains unknown whether chemo-treated cancer cells can activate the CD8 T cells independent of MHC class 1. And also whether such MHC class 1 independent CD8 T cell activation can be exploited for cancer immunotherapy. So the objective of this project is to understand the mechanism or figure out the mechanism of MHC class 1 independent activation of CD8 T cells and test whether the CD8 T cells activated in this manner can be used for cancer immunotherapy. So the first question we ask, do chemotherapeutic agents treated cancer cells even activate the CD8 T cells? So we set up this experimental system. This is a co-culture system, so we can treat the lymphoma cells with this chemotherapeutic drug called cytarabine for 16 hours. Then we washed away the chemotherapeutic drug extensively. And then we added the naive or total CD8 T cells isolated from naive mice. So you have untreated lymphoma versus treated lymphoma. And 3 or 4 days later, we analyze the CD8 T cell function. So if we have the T cell only in culture, or if this is untreated lymphoma cells, and this is doxorubicin treated or ARAC treated lymphoma cells, you can see these 2 groups activate the CD8 T cells significantly. And this is just some quantification. So we also test the other cancer cell lines. This is a B16F10 melanoma. This is MC38 colon cancer. So doxorubicin treatment can also activate the CD8 T cells. So what are the phenotypes of those CD8 T cells? So we get on the granzyme B. Oh, by the way, granzyme B is an effector molecule of CD8 T cells. They use this to kill target cells. If we get on granzyme B positive cells versus granzyme B negative cells, you can see the granzyme B positive cells are CD44 positive, CD122 positive, and NKG2D positive, but the CD49D low. And this is exactly match the virtual memory CD8 T cell phenotypes. So then we also get on the granzyme B positive population versus the negative population. So you can see the positive population also EOMAS positive, CTLA4 positive, TIM3 positive, and PD1 positive, but LAG3 negative. So those are just some in vitro culture systems. So the next question we ask, do this VM CD8 T cell even exist in vivo? And how do they respond to chemotherapy? So we injected these lymphoma cells into mice. And this particular lymphoma cell line is very sensitive to chemotherapy treatment. You can see one dose of ARAC just complete wipe out the lymphoma. However, this durable response is completely dependent on the CD8 T cells, because if we use anti-CD8 antibody to deplete the CD8 T cells, the ARAC doesn't work anymore. It can still inhibit the tumor growth, but all the tumor-bearing recipient eventually relapse. And this is just showing you, if you treat the tumor-bearing mice with ARAC in the tumors, you can see there are many more CD8 T cells, and those CD8 T cells are also get more activated, and they express more interferon gamma, and this is just quantification of that. So this basically shows that the CD8 T cells are essential for eliminating B-cell lymphoma upon ARAC-mediated chemotherapy. And this is another model. Oh, by the way, we also checked the virtual memory CD8 T cells. So we used the CD44, CD122, and also CD4090 marker. So you can see upon ARAC treatment, the percentage of virtual memory CD8 T cells was preferentially increased. And also the cell number of the VM CD8 T cells was increased significantly too. And this is another independent model. We use the MC38 colon cancer model. So you can see if we treated the tumor-bearing mice with doxorubicin, there are more CD8 T cells in the tumor. There are also much more virtual memory CD8 T cells in the tumor, and the percentage of VM CD8 T cells was also significantly increased. Just to summarize this part, the chemo-treated cancer cells directly activate the CD8 T cells, and these activated CD8 T cells show virtual memory phenotypes, and consistently in vivo chemotherapeutic treatment preferentially increased the tumor-infiltrating VM CD8 T cells. So what are the mechanisms of CD8 T cell activation? So we set up this system using the transwells. Basically, we put the tumor cells on top and the CD8 T cells on the bottom. So if we co-culture T cells and the lymphoma cells can activate CD8 T cells. The T cell produce a lot of granite B. But if we separate them into transwells, we don't really see the activation of CD8 T cells anymore. So the cell-cell context is actually required for activating CD8 T cells. So the first molecule we test on the cell surface is MHC class 1. So this is a cartoon picture of MHC class 1. So we basically use CRISPR knockout the beta-2M in the lymphoma cells. However, you can see that both wild type and the beta-2M knockout lymphomas activate the CD8 T cells equally well, and there is absolutely no difference. So MHC class 1 is not required at all. And then we also use the CRISPR delete beta-2M in the MC38 colon cancer cell model. So this is the wild type one. You can see wild type cancer cells, they express class 1. But if we delete beta-2M gene, the cancer cell don't express MHC class 1 anymore. And this is just a PCR showing you in the knockout clone, both allele have deletions. However, both wild type and beta-2M knockout tumor cells can activate the CD8 T cells equally well, and there is absolutely no difference. So again, prove the MHC class 1 is not required for the activation of this virtual memory CD8 T cells. The CD8 T cell activation depends on many signaling pathways. So we test a few inhibitors with like SRC inhibitor, SYNC inhibitor, and also PI3 kinase inhibitor. So one of them worked really well. This is a PIK3 alpha inhibitor. So it significantly inhibits the granite B activation. And phospho-AKT is downstream of PI3 kinase pathway. And this inhibition definitely reduced the phospho-AKT level. And this is the untreated control. You can see there are a lot of phospho-AKT activation. And there are some prior studies support a CD8 T cell activation can also depend on TLR pathway. So we used some TLR pathway inhibitors. Only one of them has some minor effect, and this is TAC242. This is the inhibitor of TLR4 signaling pathway, binding to the TLR4 and interfering the interaction of TLR4 and its adapter molecule. So you can see it reduced the activation a little bit, but this is very minor effect. Just to summarize this part, the activation of CD8 T cells by chemo-treated cancer cells requires cell-cell contact, but the activation of CD8 T cells is not dependent on tumor-derived MHC class 1. It partially depends on the TLR4 pathway and requires the PI3 kinase pathway. However, we still don't know the dominant molecule that activates CD8 T cells in this manner. So what about the in vivo function of these CD8 T cells? Do those CD8 T cells actually contribute to anti-tumor immunity? So we tested this using an in vivo tumor model. This is a beta-2M knockout tumor model. So we basically using the CD8 knockout mice, so those mice don't express any CD8, don't have any CD8 T cells. So we inoculated the tumors. Those are the MC38, the beta-2M knockout tumors, so they don't express any MHC class 1. Then we treated the tumor-bearing mice with doxorubicin twice. Then on day 8, we adoptively transferred the CD8 T cells. We either put in total CD8 T cells, or we put in VM CD8 T cells. We basically do cell sortings, sort out those T cells which have VM CD8 phenotypes. So as you can see, this group inhibited the tumor growth most effectively. This is a VM CD8 T cell transfer plus doxorubicin treated group. And this combination therapy prolonged the survival of the tumor-bearing recipient. Remember, those are the beta-2M knockout tumors. They're extremely aggressive. However, all the mice eventually die. The total CD8 T cells plus doxorubicin also prolonged the survival a little bit. This is statistically significant, but total CD8 T cells doesn't do as well as the VM CD8 T cells. And then we test another independent model. So this is a A20, which is a B-cell lymphoma. So they also have beta-2M knockout. So again, those lymphomas are very aggressive. They don't respond to anti-PD-1. They responded to ARAC a little bit, but all the tumor-bearing recipient eventually relapsed. And when we combined this treatment with anti-PD-1 and ARAC, it delayed the relapse of the tumors. And also a subset of the tumor-bearing recipient can achieve long-term survival, but it's a low subset, only 20%. But however, we don't really know whether this therapeutic effect is dependent on VM CD8 T cells. So just to summarize this part, so we test the different combination of therapies. We have the chemo plus adoptively transferred CD8 T cells, and the VM CD8 T cells lead to a better therapeutic effects than total CD8 T cells in the MC38 beta-2M knockout model. And the chemo plus anti-PD-1 led to a better therapeutic effect in the beta-2M knockout lymphoma model. We find out that this phenotype was associated with increased VM CD8 TILs in combined treatment group. So this data collectively suggests a critical role for VM CD8 T cells in enhancing the efficacy of cancer immunotherapy for MHC class 1 deficient tumors. So the last question we ask, what about the human relevance of our findings? So we identified these VM CD8 T cells in the mouse model, but do human CD8 T cells also have similar phenotypes? So we used the different models to test the effect of chemo treatment on human CD8 T cells. So we have this lymphoma called DHL16. This is a human B-cell lymphomas. So we basically injected these lymphomas into humanized mice. So the humanized mice received the human hematopoietic stem cells, basically. And this HSC, the stem cells can differentiate into human CD8 T cells in the mice. And then once we transplant the human B-cell lymphomas, we also treated the tumor-bearing mice with ARAC. So as you can see, the ARAC treatment also increased the VM CD8 T cell infiltrating the tumors. The marker we use is EOMAS and NKG2D-A and the KIR. This is the marker for human VM CD8 T cells. And the ARAC treatment increased the percentage of total CD8 T cells in the tumor, increased the total number of CD8 T cells. And also the ARAC treatment preferentially increased the percentage of VM CD8 T cells in the tumors, and drastically increased the number of VM CD8 T cells in the tumors too. And then we also delete the beta-2M genes in the human B-cell lymphomas. So this HLA-BC are the MHC class 1 gene in the humans. So once we delete the beta-2M genes, those lymphoma cells don't express MHC class 1 anymore. And then we have T-cell only untreated and the doxorubicin treated control. As you can see, in this group, this cancer cells also activate VM CD8 T cells. This is just quantification showing you the percentage of VM CD8 T cells was significantly increased in doxorubicin treated group. And this particular group also has express more granzyme B. This is just a quantification of that. Again, this is a effector molecule for CD8 T cells to kill target cells. Just to summarize this part, the chemo-treated human B-cell lymphomas also activate the human VM CD8 T cells independent of tumor-derived MHC class 1. However, we don't know the clinical impact of this VM CD8 T cells on human cancers, so whether they can also have an impact on, for example, chemotherapeutic effect in human cancer setting. So just summarize the entire study. So I showed you so far, the chemo-treated cancer cells can activate the CD8 T cells, and those cells acquire VM or virtual memory phenotypes. And CD8 T cell activation is not dependent on tumor-derived MHC class 1. Partially depends on the TLR4 and it requires the PI3 kinase pathway. And the in vivo chemotherapeutic treatment preferentially increase the tumor infiltrating VM CD8 T cells, and also the VM CD8 T cells confer enhance the efficacy for MHC class 1 deficient tumors. And the chemo-treated human B-cell lymphomas also activated the human VM CD8 T cells independent of tumor-derived MHC class 1. Just to acknowledge the people who did the work, so most of the work was done by a former postdoc in my lab, Dr. Xiaoguang Wang, with help with from student research assistant camp. Xiaoguang is now a staff scientist at the City of Hope. We also have a contribution from other members of the lab, and Julie and Jeremy from the humanized facility at the University of Colorado provide us the humanized mice and also human peripheral blood samples, and also thanks to the funding NIH. And that's all. If you have any questions, please feel free to let me know.
Thank you, Dr. Jingwang. Thank you for your excellent presentation. Yes, yes, we are open to questions now. If anybody has questions, please ask.
Is important for activation of memory T cells there, right? And so one thing which I don't understand is like when you're looking at like MC38 cells, they are highly immunogenic in nature. They also have high mutational burden. How that affects any of those response that you saw in terms of virtual memory formation?
Basically, those cells we used, they all have beta-2M deletions, so they don't express any MHC class 1, so they cannot present any antigen to the CD8 T cells. So essentially, we're looking at CD8 T cell response independent of MHC class 1 or peptide complex. So that's the focus of the project.
So that's true for any cell type. That means either MC38 or any other cell types without this MHC presentation. That's what it means, correct?
Yes, but we artificially delete the MHC class 1 in those cells.
And is that the case with the wild type colon cancer, like in terms of the reduced MHC class 1?
The wild type MC38 express MHC class 1 very, very well. So they will, like you said, they will induce CD8 T cell, conventional CD8 T cell mediated immune response, I think.
Yeah, the reason I'm asking is, as you know, this MC38 is MSI phenotype with the increased tumor mutational burden.
Yes.
And whether that has anything to do with the MHC class 1 expression, whether it's an independent.
Oh, I see. I don't know, but the only thing I know is those MC38 colon cancer cells, they express class 1 very highly. I don't know whether that level of MHC class 1 is affected by mutational burden in the cancer cells themselves. The one thing I know is MHC class 1 expression can be regulated by many pathways. For example, interferon gamma pathway. If you treat your cancer cells with interferon gamma, it will upregulate your MHC class 1. It can also be regulated by a histone modifier. If you treat cancer cells with HDAC inhibitor, it can also modulate your MHC class 1 level or DNA methylation enzyme inhibitor. It can also modulate MHC class 1 level. So
it's an interesting presentation. So when you look at like tumor burden or tumor heterogeneity, right? So there are different cell types within the tumors or heterogeneous cell population. Whether the MHC class 1 loss is kind of uniformly found in tumors, or it's only specific cell types within the tumor has this MHC class 1.
So there are quite a few. Actually, there is a very recent review just published on this cellular and the molecular immunology, just focus on the MHC class 1 regulation in colon cancers. If you're interested, you can look at that review. So basically, the MHC class 1 loss can happen at many different levels. They can have beta-2M mutations or deletions that will completely knock out your MHC class 1. You just don't have any surface expression. And sometimes they can also happen at a allelic level. So you may just losing HLA-A, or you may just losing HLA-B or something like that. Or sometimes it's by epigenetic modulation. They just down-regulate the level, just express lower level. They don't completely delete the MHC class 1 gene. So it happened frequently in B-cell lymphomas and the colon cancer. Those two are the most affected cancer types. But it can also happen in lung cancers and breast cancers.
Is it also because of there is an increased immune editing happening in this cancer
Probably,
types?
maybe. For example, B-cell lymphomas obviously happen in the lymphoid tissues, right? So constantly have T cells immune surveillance, and the colon also have a lot of immune cells, as your own data showed. So the colon has a lot of immune cells. They have high immune scores even in normal tissue. So maybe that's why. So, but nobody really knows. It's just a speculation. So we don't really know.
Yeah. Again, thank you for your excellent presentation. This is helpful to learn a lot of things. Thank you.
Sure. Thank you for yours too. I like your presentation too. So very interesting.
Yes, thank you so much. Thank you so much, all the participants of today. It was really interesting talks. Hopefully, you'll all join again tomorrow. Tomorrow, the conference starts at 10 o'clock GMT and 2:30 IST.
Okay, bye.
Yes,
Thank you.
Thank you.
Bye-bye.
Thank you so much.
Thank you. Goodbye.
Yes, yes.